Welcome to my podcast, The Laura Dowling Experience. Many of you will know me from my Instagram page @FabulousPharmacist, where I shine a light on topics that people normally shy away from. Today, I had such an interesting conversation with Dr Mick Crotty. Dr Crotty is a GP who specialises in weight management and obesity. I received hundreds of questions in from you about weight loss, weight management and weight stigma. I believe that we answered most of those questions today. To support the Laura Dowling Experience, see the information about our sponsors in the podcast notes. Enjoy the show. Okay, everyone, I'd like to welcome onto the podcast Dr Mick Crotty. Mick is a GP with a specialist training in weight management and obesity care, and we are going to delve deep into this subject today because it is a huge topic. I had hundreds and hundreds of questions in and comments in when I put it out that I was speaking to someone with a specialist interest in this, and I just think it's a topic that needs to really be addressed, and we need to discuss the taboos around it, the attitude that people have towards people that have weight issues, and all the kinds of things that they can do to help themselves as well. So Mick, welcome to the Laura Dowling Experience.
Thank you very much, and thanks for having me, and thanks for having these conversations. I think, exactly like you said, it's a huge important topic. It's something we don't talk about enough, and we don't talk about it in the right way. So it's brilliant that kind of we can have these chats and people can kind of hopefully learn and kind of delve into this topic.
Absolutely. So let's discuss initially the stigma around obesity, around weight, and I suppose the statistics that we have in Ireland around those issues.
Yeah, so it's, I suppose weight issues are an ever increasing problem. We know based on studies from 2015 that 60% of the Irish population over the age of 15 were either living with overweight or obesity. We don't have any more up-to-date figures than that, but it's an ever increasing problem kind of as years have passed.
Did you say 60%?
60%
wow,
of the Irish population, with probably about 23% who would be classed as living with obesity and the others in an overweight category. So this is an increasing problem, and again, there's many reasons for that, and it's there's lots of complex reasons that we can kind of get into, but I think in society, their weight is thought about in certain ways. In society, we're very thin-centric. There's this kind of cultural desire for thinness, and that's kind of an issue that has led to kind of diet culture and people doing, lots of different things to manage their weight, and often unsustainable, unhealthy, things that are not necessarily kind of good for them and are not based on any scientific evidence. There's a huge industry out there in, promoting things for kind of weight loss, and, weight is framed as the cause of and solution to all the world's problems. But when we actually look at the science, that's not the case. It's more complicated than that.
Every time you go on social media, it's like belly fat loss, how to lose your belly fat, how to lose this, how to lose that. And there's such a stigma and such, pressure on people to look thin. And I think men as well as women, and we'll discuss teenagers and what they're doing now because I've one of my own. And, it is unreal how it's actually become so embedded in culture here as well.
I think from a very young age, again, weight is stigmatized. There are people who are living with obesity, people who are living in a bigger body. There are assumptions made about them. There's assumptions made about their eating habits, about their lifestyle, about their physical activity. In studies, it's been shown that there's assumptions made about their intelligence, about their productivity. So there's assumptions made in society. There's this attitude that, if somebody has an issue with weight, they must be greedy and gluttonous. They must be eating too much and not exercising. Lazy. And all these kind of negative connotations. And actually, that couldn't be further from the truth. When I kind of in my clinic, when I'm seeing people and chatting to people, the vast majority of people I meet are struggling with weight, despite the fact that they are very clued in, they're very knowledgeable about nutrition, they're very focused on their eating habits and eating patterns, they're as physically active as they can be within their body, and yet they're still struggling with weight. The vast majority of people that I meet have lost weight in the past, and they've lost large amounts of weight. This is not an issue with willpower. This is not an issue with motivation. This is not personal responsibility. Our weight is not actually within our control as much as we would like to think.
So can I just stop you there? When you say it's not personal responsibility, so a lot of people will have an issue with that statement because a lot of people say, just eat less, move more. You've eaten yourself into this fat body. Like, you hear it all the time. So how is it not personal responsibility? Discuss the kind of the science behind that and so everything that goes with that.
I think if we look at the reasons why people struggle with weight, the causes of the chronic disease of obesity, we can look at the genetic contribution, and studies have shown that somewhere between 40 and 70% of our risk of whether we're going to have an issue with weight over the course of our life is genetically conferred. So this runs in families. The genes that code for weight predominantly code for what's going on in our brain. The brain is the organ in the body that will regulate weight. And we're talking about kind of subconscious parts of the brain that we can't control. There's an area called the hypothalamus and another area called the limbic system. Our hypothalamus is kind of this caveman, kind of, prehistoric part of our brain, and it's really responsible for keeping us alive. Okay, it's the same part of our brain that regulates our temperature. So the part of the brain that regulates my levels of hunger, my levels of fullness, is the same part of my brain that regulates my temperature. Okay, if I go out in the middle of winter, forget to bring a coat, I'm absolutely freezing cold, I can't think myself warmer. That doesn't work. Okay, because I can't affect my biology by thinking, because this is the subconscious brain. In the same way, we can't think ourselves less hungry, we can't think ourselves more full, because these are biological drives. And everybody inherits a different appetite system. So my appetite system is different than your appetite system based on my genetics, and then many different things, over the course of my life, experiences, dieting.
Like nature versus nurture type thing you're talking about as well?
It's a case of there's a genetic predisposition, there's a biological drive towards food. And some people, because of their genetics and because of their life experience, their appetite system is dysregulated. So we get increased levels of hunger, we get lower levels of fullness. So on a biological basis, people are hungrier. And this is not that people are sitting at home eating garbage all day and not exercising. It might be that my brain is driving me to take 1%, 2%, 5% more than my body requires on any given day. Or maybe for months on end, I'm doing, I'm working neutral, but then, a stress comes along, or maybe a trauma comes along, or maybe a holiday or Christmas. So it can be more episodic. So this is much more complicated than we would like to think. So other than kind of hunger and fullness, which vary person to person, we also have kind of the reward that we get biochemically in our brain from food. So dopamine, kind of these opiate receptors, cannabinoid receptors in our brain are responding to food on a kind of a chemical level in our brain.
So like that term comfort eating is what you're talking, like, that feeling that you get, that euphoric feeling that you get when you eat is similar to the euphoric feeling that you can get, doing other things like drugs.
Absolutely.
All those kinds of things.
So, and really it's different person to person. Mm-hmm. So if I have something tasty to eat, and we're not talking about eating broccoli or carrots here, we're talking about calorie dense kind of foods that are really tasty, and the response they give us in the brain. There's excellent studies looking at kind of people who are living with obesity and people who are not, where they do kind of MRI scans and they look at the activity in these parts of the brain. And you can see a difference in the activity in that part of the brain. So if I'm getting a much stronger response from food, if I'm getting dopamine, if I'm getting the pleasure hormones from food, and I'm getting it more than you, then I'm going to be more at risk of taking those foods. And if I'm tired, or if I'm stressed, or if I'm angry or emotional, or if I'm dealing with kind of stuff, or I'm busy, it's only natural then that food for some people, becomes, as you said, kind of a comfort or an emotional regulator or a go-to. It's the reward and the sabotage, because of the chemical response we're getting. Mm-hmm. So again, I think about genetics, I think about kind of our appetite system, levels of hunger, levels of fullness, and this kind of chemical reaction we get from food. And it's not a level playing field. We're not all dealing with the same appetite system. So some people, because of genetics and because of their life experience, their appetite system is making it, they're more at risk of taking more than their body requires. So they are hungrier, they are less satisfied by food. And actually kind of increasingly we are now saying that it's having that genetic predisposition, it's having that kind of biology going on that causes us to take in more than we need. So that's why we will live with overweight or obesity. So it's not overeating that causes obesity, it's having the chronic disease, having the kind of genetic predisposition, having the biology that causes us to take in more than our body requires. And again, if you had 100 people and you fed them exactly the same thing over the course of their life, they wouldn't all be the same size. We could all eat and drink the same thing and we wouldn't be the same size, for the same reason that I'm taller than somebody else has bigger feet than me. We're all unique. We're unique in our biology, in our genetics, in our experiences. The things that some people have to deal with over the course of their life, from illness, pain, being on certain medications, trauma, lots of other factors will further then change that appetite system potentially increasing our risk of struggling with weight.
Okay, and because, they say here in Ireland we're going very much like America in terms of like there's huge obesity levels out there. And I suppose we're lucky enough to live in a country where food is readily available for the most part for most people. So that argument where, you don't see any obese people in, Africa, or you don't see in developing countries, but are you saying that if there was ample food there for people to eat, then they would have the same issues as well that we do? It's just because food isn't in abundance in certain countries.
I think it's really in my mind, it's the perfect kind of storm of genetics, biology, and the world we live in. So undoubtedly the world we live in has a big impact on this, our levels of sleep, our levels of stress, sedentary jobs, commuting, the types of food that are available, ultra processed, calorie dense, kind of ultra portioned foods. All of these things further have an issue. Advertising, screen time, the marketing of foods to children, like all of these things have a major impact. Really, again, the way I think about it is that humans evolved to survive when food is scarce. That's what our biology is set up to do. In a healthy state, you don't see any other animals on the planet dieting. It doesn't happen. You don't see cows or pigs or chickens going on a diet trying to lose weight. It is not natural for people to lose weight. So, that's the way our biology evolved to allow us to survive when food is scarce. But now the biology that previously protected us in a different world, in a world where there wasn't the availability of food, where there wasn't these unnatural foods that don't exist in nature, in that world, we survive very well. But now all those protective mechanisms that previously kind of helped us survive are now causing us to struggle with weight.
Yeah, it's, when you break it down like that, it makes it much more easy for people to understand why people might overeat in the first place. Isn't that right?
Absolutely. And I think it's a case of, this isn't, I go back again and again and again to people, when I see people in clinic, they come in and the first thing they're kind of telling me is, I don't eat, I don't eat a lot of chocolate. I don't eat crisps. I'm not kind of, having takeaways and else. And I have to stop them and say, I know. Because this is the myth that's out there. This is the myth that, you must be eating garbage, you must be not exercising, that's why you've got a problem. If you just eat less and move more, you'll be grand.
Yeah.
And to my mind, telling somebody who's living with this chronic medical issue to eat less and move more is a bit like telling somebody with depression to cheer up. I think it's a lovely idea.
Yeah.
But it is a gross oversimplification, and it is frankly offensive to somebody to tell them, listen, cure your depression by just cheering up.
Yeah.
Or, you've got asthma, listen, if you just stop coughing and take a deep breath and don't wheeze, you won't have asthma.
Yeah.
It's an oversimplification to think it's that easy over the course of our life. Most people that I meet have kind of, reduced their calories, they have gone on diets and they have lost weight. But that weight tends to come back because of the complexity. And, again, if we go back into the science, which again, I think really is vital to me, and that's what I spend most of my day talking to people about, is the reasons why we struggle, the reasons why we regain weight, because it helps people understand their lived experience. It helps them understand why this isn't their fault, why this isn't kind of willpower and motivation, why it's much more complicated. So again, within that kind of subconscious part of my brain that I can't control, I have almost like a thermostat or a set point or a memory for weight. So whatever the highest weight I have been in my life is essentially etched in that part of my brain. And my brain thinks that's where is normal for me, and it will try and bring me back to that weight as a protective mechanism. So the caveman isn't supposed to lose weight. So, if he's going through a period where there's no food and his weight is coming down, to survive, his weight needs to get back up. Okay, and that's what happens to us now in the modern world as well. So in response to weight loss, if let's say my weight is at 20 stone and I'm a caveman and there's no food, or I'm a modern man and I go to a slimming club, or I go on a diet, or I adopt the latest, greatest kind of fad that's out there, and my weight comes down, which it often will if we create a calorie deficit. In response to that, the rules of biology in my body change. The pitch becomes more tilted against me. My levels of hunger hormones, which are already an issue for me, which is why I struggle with weight in the first place, get increased further. My levels of fullness hormones, which are an issue for me because I don't have enough of them, go lower. My metabolism changes slightly to slow down a little bit, and the reward, the chemical reaction, the dopamine, the pleasure response I get in my brain from food is hyperactivated. So all of a sudden, in response to weight loss, I become biologically hungrier. I become biologically less satisfied by food. I get more of a chemical response from food. So even though I'm maintaining exactly the same amount of effort as I did at the start of the diet, now the pitch is more tilted against me. And that's what promotes our weight to come back up.
And that's what a lot of people message in saying, I'm in calorie, like someone messaged me and saying I'm in calorie deficit, I'm eating 1,800 calories a day and I can't lose any more weight and I'm starving and I'm hangry. How do I, what's happening?
Yeah. So I think it becomes, as we repeat this cycle of constantly dieting, constantly losing weight, essentially it's, not that our body is learning from what we're doing, but our body is adapting and developing to prevent weight loss and to encourage weight regain. And for most people, their weight comes back up and we get back to the weight we were before we went on the diet, before we got in the merry-go-round. But now we're hungrier, we're less satisfied, and we're more driven towards food. We crave it, we want it, we need it more. It's there ever present. It's constantly in the background. And I talk to my patients about this kind of caveman in the back. I think of the appetite system like the caveman. And my caveman is louder, he's hungrier, he's less satisfied, and he's constantly roaring and shouting at me for food. And if I take my eye off the ball at all, if the smart person up the front who's making the decisions of what I do day to day, if that person gets distracted, they get tired, they get stressed, the caveman gets his way and he gets through. And that's where we go for these kind of autopilot, automatic behaviors where we're not even aware of what we're doing sometimes. Without even knowing kind of the amount that we put on our plate might change, we might kind of pick or snack on something. And that's the caveman getting his way. So we get back up to the weight we were. And the problem is we now have this new appetite system that's even more making us at risk, and our weight goes up further. And then
goodness.
The thermostat in the brain then gets reset at the higher level. So this is a one-way system. It doesn't. Yeah. We can't reset our thermostat down. So most people I meet, they're losing weight, they're regaining and gaining a little bit more. That becomes the new normal. Okay, I'll try the next diet, I lose weight again, and then I regain it and a little bit more. So most people I meet are constantly losing weight and regaining weight, but ending up at a higher point. So this kind of yo-yo weight cycling effect.
And that's the thing. So in terms of, you've discussed a little bit there about the diets. So we all know over the years, when I was in college, it was the Atkins diet. And I remember friends of mine doing it. They'd go to Eddie Rockets and eat the chicken wings. And they, but they did lose weight. And, so we have Atkins, you have keto, you have intermittent fasting. I want to talk to you about that because people swear by that, but I don't see how that's a good thing, because I just think that it's, we're not, although people say constant snacking is bad for you because you need to give your brain time to switch off. So can we discuss those diets and what you think of them and what people should actually be doing? And this everything in moderation thing, is it viable?
So I think we can look at, and you could name any diet at all, and every month, every year, there's a new diet, there's a new book out, there's a new fad. In studies where they've looked at kind of weight change over time, there is no evidence that any one diet is better than another long-term for managing weight. Okay, so to my mind, dieting, again, for the biological reasons we've mentioned, we are, if I'm doing something that is unsustainable, that is not enjoyable, and I'm miserable, that's not going to work for me long term. I can't live the rest of my life doing that. If I'm somebody who enjoys eating low carb, let's say I cut out carbs out of my diet and I enjoy that type of food and I'm not miserable, I'm not constantly hungry.
Convincing myself that I enjoy it.
So if that's the case for me, then that might be a more successful pattern of eating. So, really when it comes to kind of diets, no one pattern of eating is better than any other long-term for managing weight. It comes down to the individual, what they enjoy. So, our eating patterns should be based on our preferences for food, culture, religion. If somebody has intolerances or diet, it needs to be flexible, it needs to be sustainable, affordable. There's no point me telling somebody, well, listen, eat avocado and prawns. Oh, I'm allergic to prawns and I don't like avocados. Or, maybe I'm living on job seekers allowance. I don't have the ability to buy the fresh produce, the fresh fruit and vegetables you're talking about. I need to feed my family. So, with kind of food security is an issue. So people are buying kind of, frozen foods in supermarkets that are cheap because they can feed their family. And you can understand why people are doing that, and it's not their fault. Again, that's where kind of, the social aspect of this and kind of the environmental aspect of this comes in as well. So,
sure, it's huge. Sure, like a punnet of strawberries is more expensive than, say, a McDonald's burger.
Yeah. Regardless of our size, we should all be focusing on healthy eating, whatever that means for us. We should all be focusing on physical activity, because healthy eating will make us healthier. It will make us live longer. Physical activity will make us live longer. It will make us healthier. We will feel better. Okay, but exercise and diet in those terms, or eat less, move more, which is how it's usually packaged, is not a treatment for weight long term. It doesn't work based on the sciences. So we really need to focus on kind of the treatments that do work for people. But again, we can, don't get me wrong, we talk about kind of this is, I talk about this as a medical issue. I talk about the biology underlying it and why a lot of the things people are doing, maybe long term, are not successful for them. Mm-hmm. That doesn't mean we don't have a responsibility to address this. It doesn't mean we don't have a responsibility to kind of, to follow evidence-based treatments. And evidence-based treatment exists, but the problem is that we're all kind of brainwashed to think this is my fault, this is my responsibility. And with each time we lose weight and regain it, weight cycling, the physical and psychological impact that can have on people, the negative kind of effect of, oh, you idiot, and you've done this again, and why am I doing this to myself? Because we're told this is our fault. Mm-hmm. So I'm just saying here that this is not within our control as much as we would like to think it is.
Okay.
This is a medical issue. So I talk to people about the chronic disease of obesity, and to me, language is vital around all of this.
Well, you're using terms like living in a bigger body and unhealthy eating rather than fat and obese, which is important.
Because I think in society, and you touched on kind of stigma and weight bias, they are a major problem. If you see any news article, if you see anything in a magazine about weight, you'll see, the classical picture of a rotund abdomen with somebody holding a burger, sitting on a park bench, sedentary with their head chopped off. Mm-hmm. Like that's the classical kind of, or, somebody standing in kind of a fast food restaurant or something like that, because that's how it's framed in society. Or you're eating crap and you're not exercising. Whereas that's not the case. So to me, I talk about this as a medical issue. Language, I think, is vital because it's one of the ways that weight is kind of stigmatized. Now, in my clinic, different people prefer different terms. So sometimes I'll talk about excess weight, sometimes I'll talk about overweight. The word obesity is very, very stigmatizing as well to some people. So I talk about the chronic disease of obesity. We, in the past,
as opposed to you're obese, it's the chronic disease of it. But I think COVID also brought into focus a lot of weight stigma as well, because obviously people that were overweight and obese were more likely to succumb to more severe problems with COVID, and therefore it was framed as the fatties get it and it's their own fault if they do, you need to just lose weight. So that actually caused a lot of difficulties for people, I think.
Yeah, and I think, people were getting a call about going for a vaccine, early on in kind of vaccination, kind of when they were being rolled out, and said, well, why am I eligible for this? I don't have asthma, I don't have diabetes. Oh, it's because your weight is above a certain level, because you're, and you use the word obese. So really, we're moving away from, saying somebody is obese, to me, is like saying somebody is demented. It's like saying they're cancer. So you don't say you are a cancer person.
Yeah.
You are an obese person. You're a schizophrenic person.
Yeah. You say you have schizophrenia.
Exactly. So people are not defined by this medical problem. It's something they're living with. So we should talk about people living with obesity. We should talk about kind of, living at a higher weight, somebody in a bigger body, and ask people what terms they would like to use. Because people will often come into me and they will use very derogatory language about themselves. They will be very, very stigmatizing about themselves. Because a lot of people, and most of us carry this internal blame and shame. Society is telling us it's our fault, but we often feel that ourselves because that's what we're conditioned to believe. And that actually long-term makes it even more challenging for people to manage their weight because they're blaming themselves for it, and they use kind of very awful language, and they'll tell me, I know what to do, I just need to do it, and this is my fault, and like you said, I've eaten myself into this situation. But when we explain to them the science, when we explain to them the biology, when we explain why this isn't their fault, this is a medical issue, then the relief a lot of people can feel on that. We don't blame. I see a lot of parallels between kind of the way we talk about weight now and how we used to talk about mental health.
Yeah.
In the past, people used to be stigmatized. It was a deficiency. There's something wrong with that family, years ago. Mm-hmm. Now we know, mental health issues, there is a genetic component, there's an environmental factor. We know the biochemistry of what's happening in the brain. This is a medical problem, and treatments exist. And different treatments work for different people because we're all unique and, we're all individuals. So it's about talking to people about kind of, the treatment options that are available to them. But again, we've moved away from stigmatizing, and actually, there is a very open conversation about mental health in society now, which is fantastic.
Yeah.
That's the way it should be for weight.
So with the stigmatizing of people that are living in bigger bodies or that are overweight, there is an awful lot of weight shaming, even amongst healthcare professionals as well. And it's almost like well, if you lost weight, you'd be all right. When they go to the doctor, or when they, depend on who they're talking to. And that's an issue as well, isn't it? It's about educating everyone.
Yeah, and that's something I'm really, engaged on or kind of passionate about, is that, when I went through medical school, I did some training, surgical training first, and then I transitioned to be a GP. During my undergraduate and postgraduate education, there was no education around weight. This science that I'm talking about is not anything I learned in college. It was only later in my career that I came to this. And it was almost like a eureka moment of kind of, why did I not learn this? This helps me understand why people have an issue. It helps me understand my own lived experience of this, that this is not our fault. How did I not learn this in college? This science is not new. It's been around for a long time. Why are we not taught this? And exactly as you said, like, again, I worked as a GP for many years, and I'm almost like the kind of the born again Christian kind of reformed kind of addict, that, I have fallen into every single trap that you're talking about. I have done all the shaming and blaming, much to my own kind of,
horror. Yeah,
exactly.
When you think back on things that you may have thought about people, and maybe...
And it was pure ignorance on my part, lack of understanding, lack of knowledge, and lack of skill, that I, no matter what problem somebody comes in with, if you lost weight, that would get better. You'd have somebody come in and they'd have blood tests done, and their cholesterol is perfect, their blood pressure is perfect, their blood sugars are perfect. And you're annoyed. The doctor is annoyed that all my blood tests are perfect, because I've nothing to beat them with. I've nothing to kind of blame and shame and kind of say, look, you need to kind of work on that. And I did tell people, it's simple, just eat less and move more, because that was my understanding of things from society.
And packing people off to do that without any kind of regime, or like it's very tough for them.
No support at all, no kind of, understanding of it, or telling them, well, I did this thing before, it worked for me, why don't you try that? Like this kind of thing, is not the way, even the way we bring up weight, the way we talk about weight. So somebody goes into the doctor, jump up there in the scales, we see how big you are, or, this type of thing. When we are talking about weight, we need to ask people's permission. We need to introduce it in a non-judgmental, patient-centric way, or person-centric way, to put them, at the center of the conversation, to allow them to kind of guide the conversation. Yeah. So there's, again, when I moved to Canada and I got some extra training there, and came across kind of how they do things kind of slightly differently, they use different techniques. There's something called the 5 A's of obesity management. And again, the most important one is asking permission. Do you mind if we chat about your weight today? Would it be okay to chat about weight, or how do you feel about weight, or does weight, have an impact on your life or on your health? Yeah. And people can tell me that, no, I don't want to talk about it. That's perfectly fine. They shouldn't have to talk about it. They shouldn't be put in a situation where they're not given a choice. But again, if I ask somebody's permission, would you like to talk about weight? Is it okay if we talk about weight? Then if they say yes, then we can get into a proper conversation about it. If not, maybe they go away, but they know that doctor is open to talking about this. They haven't blamed me, they haven't shamed me, they put me at the center. So these should be non-judgmental chats. We should kind of share an understanding of the science to show why this is not somebody's fault. And then we can talk about kind of, different treatment options that are available. And, we talked about diets. I am 100%, we see these diets are almost like religion. They've taken over from religion. There's this kind of, I'm a low carb, I'm a keto, I'm an intermittent faster. Yes. And people live their life and they're defined by it. And God forbid you'd go for lunch with them or go out with them.
And it's almost like a control thing too, because, even, and I'm not being disparaging, but there's a lot of people say that follow very controlled, strict diets, like say vegan diets or vegetarian to a lesser extent. But then you may see that they're doing this and they're doing it in a very controlled way. But then they might come out with the fact that they may have had an eating disorder earlier on in their lives. So this might be a way of them replacing one control over their diet with another control over their diet. And although it's subscribing to the healthy vegan option, it might not necessarily be the healthiest way to live for their own mental health, as opposed to not even talking about their physical health.
Yeah, and absolutely. I think, the way kind of humans, kind of the way we interact in the world, we're sometimes very kind of black and white, all or nothing. Like you said, it's very difficult to do things in kind of moderation. So we can have something or we can't have it. And sometimes it's easier to not have it because that takes the thought out of it. It takes the decision making out of it. The kind of smart person, the prefrontal cortex, the modern man who's driving the bus has a lot of decisions to make day to day, and it's totally exhausting. So if he doesn't have to think about it, if he can kind of, just say, this is what I'm doing and and there's no choice, then sometimes that's easier in the face of, he's also trying to juggle all these other kind of balls in life between kids and work and commuting and paying bills and lack of sleep and stress and everything. So if we have kind of absolute kind of, black and white, it's almost easier sometimes. The problem is, a lot of times those things we're doing are potentially unhealthy. Mm-hmm. They're not sustainable. They're not enjoyable. So that's why they're not going to work long term. On top of the fact that our biology is adjusting, if that kind of pattern of eating is we're following it to try and manage our weight, in the face of kind of all that, if our weight is coming down, then our biology is adjusting to what we're doing to try and encourage our weight to come back up. And then the problem is, people talk about, I fell off the wagon or I went on holidays. But it's not that they're running out of willpower. It's not that they're running out of motivation. It's the rules of the game are changing. And we are all dealing with different rules. And, you might have some person say, well, I'm actually very controlled on my eating and I have a lot of willpower. And there's this kind of almost moralization that I'm a better person because I can control what I eat and therefore I don't have an issue with weight. And what I would say is that person is dealing with different genetics. They're dealing with different hormones. Their brain is different. They don't have this medical issue. They're not any better or worse. Food doesn't have moral value. There's no food is good or bad. It's not kind of, this kind of good or evil. I'm not being bad if I take a certain type of food. Food has different nutritional composition. Some foods are, our bodies respond differently to different foods and different people kind of respond differently to foods. So it's a case of, when we are taking foods, we're often kind of, we should be focusing on kind of what's the best fuel for our body. What is kind of sustainable for us, what is enjoyable for us. And I am utterly agnostic when it comes to diet.
Okay.
There's no, I will ask somebody, what pattern of eating suit them. Again, you talked about, intermittent fasting, and some people will kind of, go long periods without eating, and that might be sustainable and enjoyable for them. We know that if we go long periods without eating, that reward pathway, our hunger hormones, I meet a lot of people and they say, I don't understand why I'm gaining weight. I don't have breakfast, I don't have lunch, I eat once a day and I'm still gaining weight. And we say, okay, well, from a biological point of view, we know if our body, for some people, if our body goes long periods without eating, our hunger hormones might be very, very high. The reward pathways are hyperactivated. So then when I do take food, I'm much more high risk of taking in more than my body requires because of that kind of biology that's going on. So let's say I was, previously taking 20% of my food intake in the morning time, 20% at lunchtime, and 60% in the evening. If I'm taking 0-0, I'm more at risk of taking 105 or 110% in the evening time. Or I'll eat and I'll not be full, so then I might kind of pick or snack. And again, our brain is very, very smart. It'll kick in with these permission thoughts. Well, you didn't have breakfast, you didn't have lunch, you went for a walk today. It's a Thursday. You couldn't start a diet on a Thursday. That's ridiculous. It's the 28th of the month. Who would start a diet on the 28th? We have to wait to the 1st. Again, these permission thoughts kick in to allow the caveman in the back who's roaring and shouting to get his way.
Yeah.
So I think about the kind of smart, modern person battling against this caveman all the time. And some of us just have a louder caveman, and that's why we're more at risk.
And what do you think then about people that say they're very good, very controlled during the week? And even that word controlled, I hate. But say 6 days a week, they eat very well and they're, almost in calorie deficit. And then you hear about these cheat days. So you can have your cheat day. That to me, it just, I grew up with a very kind of, standard, I suppose, 80s childhood. Mum cooked every day. We got very... like a takeaways maybe once a year or something like that. So I have it naturally in me to kind of cook healthily and I have that genetic thing that you're talking about. I think that it's just in me to eat well. I don't necessarily yo-yo in weight either. And I agree it's genetic. So people that do that very controlled eating 6 days a week and then they fall off the wagon, so to speak, on a Sunday, but deliberately to go out and they just go mad or they drink loads. What are your thoughts on that?
So I think, again, routine can be very, very protective for some people. Having a routine, having a structure to the day. So maybe kind of if we're in work, if we're in a different environment, we don't have the access to things. The caveman finds it harder to get kind of access. They're not ever present there. So, if we don't have access to something, it's unlikely we're going to jump in the car and drive to the shops to get it in that moment. So a lot of this is autopilot, kind of it's almost automatic kind of behavior. And it's conditioned behavior and it's how we were brought up and there's lots of different kind of factors going on. So routine can be very, very good for a lot of people because, if we're distracted, again, maybe kind of, the caveman isn't as loud kind of because we're being distracted or we're thinking about something else. So for some people, routine is very, very good. And it might be that, at the weekends, kind of they don't have the same routine, or they, again, these permission thoughts of, well, I'm allowed to do this because it's the weekend and I can do that and life is short and I'm going to live my life. And again, that might contribute to weight issues for some people. So I go back to kind of saying, this is not a case of I'm eating crap all day and not exercising. This is more complicated. So as I said, some people might be running along totally kind of static months on end, but then a holiday or Christmas, it might be more episodic. It might be, I'm asthmatic, and I had a bad flare-up of my asthma and I went on some oral steroids, and we know that the effect that has on kind of our appetite, and as a result of that then I took more food, so then now my weight is pushed up, I've stayed at that level, and my thermostat now is up at that point. So again, this to me is kind of more complicated, and again, it's a case of there are people who don't have issues with weight, who have very unhealthy diets, who eat. We all know of people who kind of feel they can eat and drink what they want and never have an issue with weight.
Yeah.
And the likelihood is that they're eating, drinking what they want, potentially not eating healthy, but maybe they're just taking less of those foods because of their appetite system.
Yeah.
I meet patients every day who come to me and, we go through kind of, what is their story? We listen to them. We kind of have different ways of kind of assessing, over the course of the day, what are the things they struggle with? Do they struggle with snacking? Is it that they feel hungry more of the time? Is it that they don't feel satisfied by food? The amount of people that I meet who say, I don't know what fullness feels like. They've never had that experience in their life. And then we treat them, and we can talk about kind of different treatment options, but we treat them and they say, for the first time in my life, I know how other people feel after eating.
Isn't that amazing?
And it's mind-blowing to them because they turn to me and they say, is this how other people feel normally?
Yeah.
I don't like the word normal because there's normal? No such thing as normal. But I suppose what they maybe are meaning is this how people who don't have an issue with their weight feel naturally?
Yeah.
And it is. And that's why those people don't have an issue with their weight, because they have lower levels of hunger, they have higher levels of fullness, they get less of a chemical response from food. So again, the rules of the game for that person. Now, that person who doesn't have an issue with weight might have other challenges. They might have mental health issues, they might have asthma, they might have another medical condition. But it's amazing to me, and I suppose I feel this area of medicine that I'm very lucky to kind of practice in this area. I find it really, really gratifying, and it's a really selfish area of medicine, because I have people coming back to me who have this experience, who get treatment, and for the first time in their life, they're not blamed and shamed. They're it's explained to them.
Yeah.
We talk about it, and that makes sense to them why they have kind of the lived experience they have. We talk about treatments and we put them on treatments, and they come back and they say for the first time in their life, their relationship with food, they're not terrified of food anymore.
Isn't it awful that even the fact that they say they're terrified of food, or they hate food, they have a love-hate relationship with food? So can we talk about treatments now? Because that's a huge area of your practice, and it's a huge area of medicine in general. And then obviously there's people that want to take the treatments for obesity just to lose a few pounds for, say, going to a wedding and your thoughts on that. So let's discuss treatments.
Yeah, and again, this is what I chat about every day, and I'm a bit odd because I really like chatting about this. But
see, this is what this podcast is about. It's about finding odd people that like chatting about different things.
I'm very odd in lots of different ways. My wife will tell you the same thing. But yeah, so I suppose just before we kind of chat about treatments, I think is to kind of share with people kind of what we mean when we talk about kind of obesity as a chronic disease.
Yeah.
So, previously when I'm talking about weight, I genuinely, honestly could not give a flying whatever about numbers on the scales. I don't care about size.
BMI.
Oh my God.
I hate BMI.
Don't get me started on BMI.
I want to get you started on BMI because
BMI, I remember I looked up the history of BMI. It was developed by a Belgian statistician back in the 18 or 1900s, not as a marker of health. It is a marker of size. it tells us about our size on this planet. It doesn't tell us very much about health. It has some utility and usefulness if we look at population-based studies. When you're looking at large groups of people and the size of people in society, it has some benefit. But as a marker of health, it is not very good at all. It doesn't correlate well with health. And really, for me, all of the chats I have about weight come back to health. It's not about size. It's not about weight. It's not about this cultural desire for thinness. It's about health. So the more modern definition of obesity as a chronic disease really is excess or atypical adiposity. So excess or atypical fatty tissue that has a negative effect on health. So it's for some people, they are carrying weight and that weight is having a negative impact on their health. So that person has a medical problem. If somebody is a bigger person, they're living in a bigger body, but they don't have any impairment of health, that person doesn't have the chronic disease of obesity. They don't have a medical problem. They're just a bigger person and they should live their life and they should enjoy their life.
And as long as they're healthy, because those questions did come in, like, I mean, my BMI is over 27. Technically, I'm overweight. But what am I, but I live a healthy life. I exercise, I eat well. So is there a problem with me?
No, so those people should focus on healthy eating. They should focus on physical activity. And they can be kind of conscious of their weight. Some people are into tracking weight and monitoring, and that's absolutely fine. That's not going to necessarily give us eating disorders or create problems for us, as long as we have a balanced kind of view of it and as long as we're aware of things. To my mind, if somebody has an impairment of health, when I think about health, I think about psychological health and well-being. I think about function and kind of mechanical health, so our ability to do the things we want to do, our joints, our ability to be kind of down on the floor playing with kids or grandkids, going hiking or walking, not having kind of, physical impairment as a result of weight, or our metabolic health. So if we have an impairment of our psychological health and well-being, our physical, mechanical, functional health, or our metabolic health, then this is a medical issue, and that person then deserves to treatment and deserves to kind of talk about treatment. And we can talk about the different treatments that exist, but really this is not about size. This is not about making everybody conform to society, what society tells us. This is about health. And if we look at kind of the evidence, weight has a variable effect on different people. One person can, if you look at kind of numbers on the scales, if you look at BMI, they might be at a much higher level, but have no impairment of health. You can have somebody else who on the scales or in the BMI scale is at a much lower level, but has lots of medical complications as a result of weight. So it has a variable impact. So we're all individuals, and that's a large part of this is working out, and I will ask people, does weight have an impact on your life or on your health? And if so, how so? I don't make the assumption that it does, because it doesn't for everybody. And it's not, I
suppose, and it's someone's perception as well. Sorry to cut across you, but I suppose, the way if someone is living in a bigger body, but they're exercising to their happiness, I suppose. They may not be able to, run 10K, but they can, walk briskly too, and they're happy enough with that. That to you is healthy rather than.
So there are lots of people out there who are fitter, healthier than me, but they're living in a bigger body. So again, I think health and weight are related topics, but they're not the same thing. Weight is not the cause of or solution to all the world's problems, which is that's what it's sold to us as. If you just lose weight, this will get better, that will get better. You go to a GP like me or a specialist, and you're told, that arthritis in your knee, if you lose weight, that will get better.
Yeah, that's huge. I see that all the time.
And I would previously have said that to people, and now I would say to them, losing weight or kind of managing weight, you may have an improvement in your symptoms, but they may have a knee issue because they were playing rugby and they tore their ACL when they were 18, and now they have kind of scar tissue and they have arthritis as a result of that. Maybe weight might be contributing to kind of symptoms for them, and for each individual, managing weight may have an improvement in health. And people do come back to me and they say, my knee is better, my back is better, my function is better, my acid reflux is better, my blood pressure is better, and that can happen if we manage weight. But it's not a foregone conclusion that weight is causing all the problems in the world. And I think it's really important, as far as these discussions, to distinguish between kind of, we know that diet culture is terrible.
Yes.
This kind of cultural strive to be thin, and as a result of that, people are dieting, they're kind of, going on fads, they're following very unsustainable and unhealthy kind of patterns of eating and physical activity that in the long term may have a negative effect on their health and psychologically. So diet culture is wrong. In my head, we need to distinguish between kind of, anti-diet culture or kind of, ending diet culture, but also offering treatment and support to people who are living with this medical issue, people for whom weight is having a negative impact on their health. Those people deserve to be treated. Diets are not going to treat them. But, it shouldn't be, in my mind, it's a case, if somebody's health is being affected, then we treat that person. But, this cultural desire for everybody to be thin, that's not right. And that can cause a lot of problems. And we know the kind of increasing issues with eating disorders and disordered eating, that are happening. So you can understand why people are pushing back against kind of diet culture. But I think we can't forget people, and their health.
Yeah, and that pushing back against diet culture, I'd like to talk a little bit about that, because there is that movement about, healthy in every body size. Mm-hmm. And, if someone is obese and, the whole fat shaming issue that goes on there too. But saying fat shaming is wrong, which it is wrong, of course. But is there such a thing as healthy in every body? Has that movement gone a little bit too far, where it's making it okay to live an unhealthy life because, God forbid, someone actually said to you, actually, it might be in your best interest to lose some weight?
So I think, again, bringing it back to, regardless of our size, we should all be focused on healthy eating. We should all be focused on physical activity, because that's going to make us live longer and avoid disease and be healthy. And that's kind of independent of size. If somebody is living in a bigger body and they don't have health issues at the moment, mm-hmm. I suppose statistically we can look at kind of the evidence, and for some of those people in the future, their risk of certain medical issues may be higher. But it's not a foregone conclusion that that person is going to get high blood pressure, they're going to get diabetes. And sometimes medical professionals will often almost threaten people with medical problems. If you don't control your weight, you're going to have this problem, you're going to die, and we're very kind of catastrophic in our thinking. And that's not the case for every person. But statistically, our risk of certain medical problems is higher if we're living in a bigger body. So kind of if somebody currently has kind of health issues as a result of their weight, or maybe if that person, in their family has seen other people with a similar kind of body shape, body size, who they share genetics and biology with, kind of developing issues down the line, there's nothing wrong with that person wanting to kind of manage their weight to improve their health long term. I suppose the healthy at every size kind of movement, it's kind of very much body positivity. There's even a movement called kind of fat activism, kind of reclaiming the word fat and using it kind of in a non-stigmatizing way that people identify, I am fat. I have some issues because I think this is a very nuanced discussion, and particularly when we go online, we know that kind of social media and the internet, we don't do nuance. It's absolutism. It's kind of one thing or the other.
They take something out of context.
Yeah, and it's a case of, I actually share a lot of kind of commonality with kind of the body positivity. I think, we know that if somebody is let's say 500 pounds in weight, mm-hmm. that person may not be any happier at 400 pounds, 300 pounds, 200 pounds, 100 pounds. It's weight doesn't necessarily equate. Losing weight doesn't necessarily make us happier. That's kind of a myth.
That's the misnomer, isn't it?
People come in, if I just lose weight, my life will be sunshine and lollipops. Like, it won't necessarily be that way. Your health might be better, but all your problems are not going to disappear when you kind of manage weight. So from the point of view of kind of accepting the body we're in, accepting that kind of, the good and kind of bad about that, not blaming and shaming ourselves, understanding that this is kind of not within our control as much as we'd like to think. I think it's about kind of balancing values. There is a value to kind of good experience in life. There's a value to health, and kind of balancing those up. A lot of people will lose huge amounts of weight, but they won't be able to go out. They won't be able to, they'll hermit away to do it.
Yeah, it's difficult to live your life if you're on a diet,
exactly.
And if you're very controlled, especially.
So I think our relationship with food is kind of very, and that's why kind of dieting causes this disordered eating, and again, the control and kind of the good and bad, and the internal blame and shame and kind of beating ourselves up. So I think our relationship with food is very important. Our relationship with our own body and kind of being positive about kind of the things we can do, healthy eating and kind of physical activity, all very, very important. I suppose my argument would be that for some people, weight is going to have an impact on their health. So we shouldn't stigmatize those people for seeking treatment. We shouldn't stigmatize those people for having bariatric surgery or taking a medication or, following a behavioral program or looking at their kind of eating patterns.
Can you just explain what bariatric surgery is?
So I think I keep talking about treatment and treatment and treatment and treatment. If we're talking about treatment for the chronic disease of obesity, for somebody for whom weight is negatively impacting their health, really there are three pillars of bariatric medicine. There are three treatment options available. We have behavioral support and intervention, which really is trying to kind of supercharge the smart, modern person who's driving the bus, trying to help keep our eyes on the road. And that can be anything from looking at kind of sleep, looking at stress, looking at our day-to-day kind of routine, looking at the medications that somebody's on. It can be kind of nutritional therapy. It can be psychological interventions, cognitive behavioral therapy, cognitive reframing, kind of these different techniques. So it's basically to help support an individual day-to-day making healthy choices. Okay, and that's, I suppose, a lot of people might feel they have done that before, but maybe they haven't done it in a
But it's not just telling them to eat less and move more, is it?
It is absolutely not, and it's not a diet.
No.
It's a case of, we might look at, okay, over the course of my day, when are my high risk times? When am I more at risk of taking more than my body needs? When might I be at risk of taking in a food that maybe doesn't align with, my weight being where I want it to be in the future? So it's a case of maybe for me, I skip breakfast, I skip lunch, evening times are my high risk. I'm sitting, watching TV, the kids are in bed, I'm finally getting to relax. That new show is on Netflix, I'm having a cup of tea, and I can't have a cup of tea without something with it. Because for the last 20 years of my life, I've associated Netflix, tea, biscuit or something else.
Yeah.
So to kind of break that kind of pattern of behavior is exceptionally challenging, because that's automatic, it's autopilot. We have done it so many thousands of times over the course of our life that it's alien to sit there with the cup of tea watching Netflix for me without a biscuit. It's almost this automatic behavior.
And it almost goes back to childhood as well. If food was used as a kind of a scene as, your mum or your dad giving you your cup of milk and your biscuit in front of the TV. It even goes back to that, doesn't it?
And it's again, how do we celebrate every happy event in life?
Oh my goodness,
with food.
Stop, I know. And everyone just wants to buy your kids sweets and treats.
It's sweets and treats, and it's a case of, every kind of event in life, from weddings to birthdays and everything, it's kind of food. And it's so important kind of culturally in society, or, certainly, again, child of the 80s kind of growing up, and kind of, you have to finish your dinner. Well, you have to finish your dinner because there's people dying in, a famine in Africa. As if me finishing my kind of carrots is going to have any impact on that. But again, this is what was sold to us. And I've chatted to people who kind of, would say, God, when I was a kid, we were given dessert, but it was given on my dinner plate. So it was served to them on the same plate that they had their dinner. So they had to finish their dinner. Otherwise, they're going to have their dessert mixed with kind of mashed potatoes and gravy and everything else. So it's like it's
that's almost cruel.
And I think particularly in Ireland, I think it's not why, and our parents felt like they were doing their best. This is how they were raised. This is as a parent, you're always terrified. Like, is my kid, when they're toddlers, is my kid getting enough? We have to get food into them any way we can. And actually, children at a very young age, unless they have kind of major, for some children who have severe issues with weight, they might have kind of genetic issues or major mutation or something. But in general, kind of for children have a very well regulated appetite system. So you'll see toddlers, and some days they will eat absolutely nothing. Other days they'll eat like an absolute horse, because they get kind of the hunger hormones, the fullness hormones. They stop eating, and nothing you can do will make them eat more, when they're full. So you can't coax them or cajole them. They'll eat or they won't. But we all, as parents, we get stressed.
And we're obsessed with getting their meals into them. And
here, if you don't have that, here, have a yogurt or have something, we'll try and get other stuff into them, because we're terrified that they're not getting kind of nutrition. They're not going to grow. They're not going to be healthy. But actually, the reason for that is, over human evolution, was there a stable supply of food? Did we have 3 square meals a day? Maybe not. So again, our appetite system, with children, sometimes they're going to be hungry, they're not going to be hungry. And it's very challenging as parents because we get kind of stressed about that. And equally, kind of if we get really kind of, thinking laterally on this, like things like the famine that happened in Ireland and how that maybe kind of changed kind of our cultural perception of food and getting food, and you have to finish your food and the foods that are available, and parents working hard to put food on the table.
Yeah.
All of the things you can't waste.
It doesn't help though either that when you have a baby, well, first of all, if you're breastfeeding your baby, you can't leave the hospital unless your baby has not lost more than 10% of their body weight. Isn't that the body weight that they're born with? Isn't that right? And then you have those milestones, those health checks. I know people that have babies that they may not have been hitting those milestones with their weight, and the mother's made to feel guilty, or maybe not intentionally, but they do. And so, and we know from ourselves, like, you're a different size to me. As a baby, I may have been slighter than you. And even with my own three children, they all put on, well, they were all heifers really, but they all put on weight in different ways. So, there are people out there that they feel that they have to stuff their children because otherwise they'll be seen like as if they're underfeeding them. So it's a societal thing from a very, very, it goes way back, doesn't it?
And I think, again, it's a case of, we feel like, oh, I'm a bad parent, or you go to somebody's house for a play date or something, God, their kids are eating very healthy and mine don't eat as well as that, and the blame and shame we kind of have. And again, I think, all of these things add further layers of difficulty. And that's why this is a really complex area.
It's very nuanced, isn't it?
Like if we did kind of a map of kind of all the things that influence weight, like, there are thousands of things out there. Again, we talked about genetics, we talked about biology, hunger, fullness, craving, wanting, reward for food, and everybody having a different system. We talked about kind of, childhood and upbringing, society, the way we think about food, advertising, medications, pregnancy, perimenopause, menopause, pain. There are so many factors that influence our intake. So, somebody could say, well, you have to put this stuff in your mouth to eat it, so it's your fault and your responsibility. It's okay, well, if I'm making a certain food choice, why am I making that choice? I might be sitting there of an evening, and I know I'm not a smart man, but I have some brain cells, and, I know about, when I'm told about nutrition, I know this is not the healthiest choice I could make. I'm a doctor who specializes in weight management. I talk about this every day. I know that this is not the best fuel for my body. Why do I take it? Why do I put that in my mouth when I'm a modern, sensible man? Well, maybe I put it in my mouth because I've done it so many times over the course of my life that it's an automatic behavior. Mm-hmm. Maybe I do it because my hunger hormones are going bananas because I didn't have enough to eat earlier on in the day. Maybe my kind of I don't have enough fullness hormones, so I'm not satisfied after my dinner, and I'm still hungry. Maybe I get a chemical response from that food that is in excess of somebody else beside me.
A nice dopamine hit.
Exactly. So again, all of this is happening kind of subconsciously, and it comes through. And again, maybe I'm stressed, maybe I'm tired. There are lots of other factors, but our biology has an impact. The foods that are available, so many things have an impact on our food choices. And there's also a case of, I'll rationalize and I'll think, well, this one thing is not going to cause issues for me, and I'll just reset tomorrow. But again, this is kind of, contributed to by kind of, thousands upon thousands of choices we make over the course of our life. But our choices maybe are not as within our control as we would like to think.
Yeah.
Because again, one of the, and again, just bringing it back to people I chat to every day, I talk to really, really successful people who have done phenomenally well in school, academically. They've done well professionally. They're really successful in their relationships, in their families. And they are hardworking, dedicated, diligent people who have applied themselves and been really successful in life. And they are utterly frustrated and pissed off that they're trying to use those skills that made them successful in life to manage their weight. And why is it not working? And the blame and shame that they get from that is, you feckin' idiot, and why can't you just do this? And, I know what to do, I just need to do it. I must hear that every single day. And it's a case of, they are trying to use dedication, hard work, diligence to manage something that's biological. So they have genetics, they have biological predisposition, and they live in an environment that's activating that. That's why they're struggling. No amount of hard work and dedication and diligence. When I meet people, this idea that this is willpower and motivation is utterly rubbish. Again, it's not within our control as much as you'd like to think. Again, doesn't mean we don't have a responsibility, but those people, come in and they have struggled with weight for years and years. It's not lack of intelligence. It's not lack of kind of knowledge about nutrition. Again, it's a biological issue.
But even on the biological issue, and this isn't necessarily to do with obesity, but say women and men, as we age, our metabolism slows. So I get lots of questions in, and I'm sure your wife does too. Menopausal weight gain. So we will often see a woman in her 40s starts to get that middle age spread, that belly. And I've had a lot of questions in, how do I get rid of the belly? I eat well, I exercise, but this belly fat I just can't get rid of.
Yeah.
And, is it just a case of we just actually need to accept that? And unless we, get liposuction, it actually won't disappear.
Yeah. I think it's a really interesting area to me. And again, probably because of culture and society, the majority of people I see in my clinic are women.
Okay.
The majority of women I see are between the age of 40 and 60. So they are traversing kind of perimenopause, menopause. And I think I will never be able to understand what they're going through because, and again, no matter how much you talk to them, you kind of gain an appreciation for what people have to put up with. And I'm acutely aware as a man who has never had to go through, puberty, developing breasts, having periods, pregnancy, and then menopause. Like, I'm incredibly lucky that I haven't had to go through any of those
We
things.
really do get the raw end of the stick, don't we?
Absolutely do. And I think kind of, there's a lot of parallels between kind of menopause and weight as far as, there's this idea of kind of put up and shut up and just get on with it. And, well, if you're having kind of a problem, that's your fault. I went through it and I didn't have any problem at all. So again, there's the blame and shame. Thankfully, we're having more conversations about this and there's increased awareness of it. And again, coming back to kind of treatment and evidence-based treatment and even having the discussions around it. Again, if we look at population-based studies and huge groups of people, and we track weight over time, we know as humans get older, we are naturally supposed to put on some weight because that actually confers a survival advantage. To have a little bit more weight as we get older is associated with kind of better outcomes. So let's say I'm older and I get pneumonia or I end up in hospital or I have a problem. If I have some reserves of weight, I will do better than somebody who doesn't have reserves. So we are supposed to kind of put on some weight. And over time, kind of if you look at kind of age versus weight, our weight will go up over time. And if you look at studies kind of, in populations, there isn't a huge kind of spike around the time of menopause across the whole population. Okay, so based on that, they have said that menopause doesn't cause weight gain. Okay. Now,
I hear women all over Ireland screaming at this.
This is why I'm going to say, bear with me here for a second, and this is much more nuanced. So on an individual basis, the case can be different. So if somebody has had weight issues prior to menopause, that person is at more risk of gaining more weight. If somebody has more severe menopausal symptoms, so if we look at some of the symptoms of menopause from, disturbance of sleep, increase in anxiety or mental health, kind of physical, kind of aches and pains, hot flashes and discomfort, all of those individual things are risk factors for putting on weight. So somebody who has more severe vasomotor symptoms, that can contribute, to weight gain. So again, pain can contribute to weight gain, again, because of the changes in the kind of the hyperactivation of the reward pathways in the brain as a result of these symptoms. So if somebody has pre-existing weight issues, if somebody has more severe symptoms of menopause, then that person can have issues with kind of gaining more weight. And for some women, it can be very dramatic that they will say, I never had a bother with weight, and then perimenopause struck and my weight has gone up hugely. Mm-hmm. The other thing that is, I think, really not talked about enough is, regardless of numbers on the scales and changes in numbers on the scales, is the change in body composition and distribution of weight. Like, how terrifying and devastating can it be to somebody that maybe their weight on the scales isn't going up, but all of a sudden where they're carrying weight is changing? And we know as kind of estrogen kind of falls, one of the results of that is actually a change in the metabolism of fatty cells in our body and where those cells are active. So women, as estrogen goes down, their propensity to kind of put on weight around the thighs and kind of bum is lowered. and the risk of putting on weight around the midsection is increased.
Yeah.
So we get this visceral adiposity, the kind of belly or tummy that you talked about. So women will kind of see a change in their body shape.
Yeah, women. I hear women saying their fat moves from their ass to their belly, so they get a flat ass and a big belly, like the opposite of what society is teaching us as sexy or attractive.
And again, isn't that devastating?
Oh, it's awful.
Like,
awful.
That's not something,
it's actually traumatic.
That's not something I'll ever have to kind of go through. But like, you have to really feel for people through no fault of their own, and they're not doing anything, with changes in hormones, that their body is changing. And we can talk about kind of loss of muscle mass, loss of bone density.
Yeah.
So if I'm losing muscle, if I'm losing bone density, my weight might not be changing, but the distribution of weight is going up. So I might get a much higher percentage of fatty tissue versus muscle and bone. As we lose muscle, we know kind of metabolism can kind of change as well. So it's if we look at kind of the idea of metabolism, and kind of this is, a lot of people will track calories, and they'll track calories based on what they're kind of recommended. All of us burn different number of calories, and my kind of body uses a different amount of fuel than your body uses. So we're all different, and they've looked in studies at kind of what the average is, and that's where we get these guidelines around number of calories a day. But on an individual basis, some person might have a much lower kind of metabolism, slower metabolism. So again, for that person, that might be one of the reasons contributing to more difficulty in losing weight, even though they feel they're in a kind of calorie deficit. Or it's a case of, the calorie trackers we use are sometimes not as accurate as we would like to think.
And they're standardized. So it's not individually, even though you have to put in your height and your weight, like that tracker can't tell what my metabolism actually is like compared to yours. But on the menopause issue, it's also a case of women postnatally, and after they've had babies, our body shape changes naturally. Like even if you're get back to your normal body weight prior to having your baby, your body shape, I don't think, or in a very minor amount of people, is the same. I think it changes. Your fat disposition over your body changes as well. So, and you do find a lot of women just find it extra difficult to lose those extra pounds postnatally.
And on top of that, then we are bombarded with kind of being ever youthful.
Oh, yes.
And chasing youth, and kind of it's all about being young and being thin. And again, so women are getting kind of multiple whammies at the same time of kind of, you need to control your weight, you need to kind of, be productive and kind of, get through menopause. And, on top of all of that, they're kind of dealing with so many different things at a kind of a very challenging kind of time of life, and their body is changing, and the loss of control of that. You talked about control, like a lot of people I talk to, they feel they're not in control of their body anymore. And again, kind of, with kind of pregnancy, again, the huge physiological kind of changes that are happening, and maybe, during pregnancy again, because, we know that there's a baby growing, and some women for the first time in their life might not be on a diet, because I'm pregnant, I shouldn't be kind of dieting, but it's the first time ever they have not dieted because they've been on a diet from, they're the age of 12. And again, the amount of people who kind of, who have been just chronically, constantly on a diet, kind of weight cycling.
Do you see people coming to you that have admitted to have been on a diet since 12? My God. So it's so sad, isn't it?
People come to me and say, I've been on a diet all my life, and yet they still struggle with their weight. So is that not proof enough to us that diets don't work? We're waiting for this new magical diet this is going to be the answer. But we keep hitting our head off the same wall over and over again, expecting a different outcome. So the amount of people, and actually the other thing I hear every single day, if I could just go back to the weight I was when I first thought I had a problem.
Oh, I know.
So people are looking back at photos saying, I had a particular kind of perspective or attitude to the way I was at that time. I'd love to be that way now. Because again, this is a chronic progressive medical issue. So it progresses over time and becomes kind of more of an issue over time. And again, totally explainable by what we talked about with the kind of set point and our body kind of adjusting and our weight going higher. So that's why we yo-yo. So the more we diet, that is one of the major factors that's contributing to gaining more weight.
That it's that thermostat analogy that you gave, actually, that I think is really, well, it's resonating with me, definitely.
Yeah, and I think it resonates with people because people say, people kind of have this idea, like, are you in my kitchen? Like, can you see what I'm doing? Because you're describing things to them that people talk to me about every day. And people are experiencing that, but they haven't spoken to anybody about it before. And I'm acutely aware of how vulnerable people are and how brave people are coming to talk to me about such a sensitive topic that is, you know, that they have been blamed and shamed for their entire life. Like, how difficult must that be for somebody to go and seek treatment and seek help for this kind of issue and talk about eating patterns and talk about physical activity and talk about how they feel about their body? Like, it puts me in a hugely privileged kind of position for people to talk about that. And again, you know, in my previous existence as an uneducated, ignorant person, before I came across the science, you know, I wouldn't have had those kind of conversations. And it was the challenge of it, you know, why I got into this was because you discover the science and you say, like, how are we not shouting this from the rooftops? How can we not, you know, impress upon people the reasons why we struggle with weight? This is not new science. Why are we not able to get this information out there? And there seems to be just kind of a brick wall. And, you know, it's not that I'm kind of shouting against the wall all day long, but it feels that way sometimes.
But what's your thoughts on those kind of programs like Operation Transformation and all of those things?
Yeah, I have lots of thoughts. I think the problem is, I think a lot of those programs maybe started with very good intentions of kind of promoting physical activity, promoting healthy activity, or promoting healthy eating, and kind of, you know, trying to help people. So I think a lot of them came from a very good place. The problem is most of them reinforce a lot of the stigma and bias that's in society. The personal responsibility, if you just exercise more, if you diet, if you eat less and move more, you won't have a problem.
And that thing of hopping up on the scales in front of everything, I just think that's so damaging, isn't it?
But also, like, it's car crash TV.
Yeah.
Like, it's the voyeurism of people. Like, why are they in Lycra? You know, why? And you can look at kind of Operation Transformation here, or you can look at The Biggest Loser in the US. Like, this is utterly kind of voyeuristic car crash television of kind of, you know, people are paraded out in knickers and bra, you know, and kind of, you know, people are watching them on TV and you know, it's to my mind, it reinforces a lot of the stigma and bias. And I think in more recent kind of seasons, thankfully, particularly with Operation Transformation, maybe they have moved away from some of those things, but at its heart, it's still a weight loss diet show.
Yes,
and I think,
and a shaming. There is a little bit of shame factor there too, in terms of.
And I think you know, again, it's a case of, I think they're maybe transitioning more to talk about health, which is a very good thing. But I think it's much more nuanced, you know, and it's focused on, you know, numbers on the scales, weight loss. People are very surprised when they come and see me. I generally don't weigh people unless.
Do you not?
No, unless they want to be weighed, because it doesn't change anything for me. It doesn't change the treatments that we offer. And I think, you know, that the numbers on the scales is not the marker of success for me necessarily. So when I bring people back, and we've got sidetracked on the treatment thing, but we'll come back to that. But when somebody is on treatment and they come back, I'll ask them about, you know, hunger levels. I'll ask them about fullness levels. I'll ask them about portion sizes. I'll ask them about snacking. I'll ask them about kind of the relationship with food, energy levels, sleep. Because all of those things are much more markers of success and health to me than numbers on the scales.
But yet we're obsessed with the numbers on the scales.
And people will generally come back to me, and the first thing they'll tell me is how much weight they've lost. And again, I'll say, okay, but tell me about this. Like, if we focus purely on the scales, we forget about the increase in function, increase in energy, change in our relationship with food, looking at the extra headspace, you know, in somebody who has spent their entire life. And, you know, for a lot of people I meet, it's not that they're hungry, it's not that they're not full, it's that they're thinking about food all the time. And how can I not take food today?
That's what a lot of the questions that come in, where I am constantly thinking about food.
And I ask people, you know, do you think, is it hunger? And say, it's not hunger. I'm thinking about how I can take in less today. How can I eat less today? How can I do that? So when we treat people, when we shut up the caveman, when we turn the volume down on the appetite system, the headspace that people have, and say, you know, I'm just not thinking about food all the time. You know, this is, you know, people use the word freedom, that the freedom this has given me. And as a result, you know, food is not good or bad. It's fuel. Mm-hmm. So as a result, people's relationship with food and can improve because they're not dieting. With the treatments, and when we eventually get to talk about them, with the treatments, you know, people are not restricting themselves. They're not saying no, no, no all the time. They just don't want food in the same way as they did before.
It's shutting off the appetite.
It's treating the underlying biology. So now somebody's brain is now behaving like another person who doesn't have an issue with their weight. And that can be huge for people as far as you know, and not to be over dramatic, but some people do come back and they say it's life changing.
Well, I can imagine why. Now let's talk about the treatments. Okay. I want to get into them.
We kind of touched on kind of behavioral interventions, and really to me, the behavioral interventions is kind of the scaffolding or nuts and bolts of kind of our day to day, and how can I live my healthiest life today? How can we keep the smart person's eyes on the road, keep engaged, keep focused, and facilitate us making the best decisions we can day to day? So, like I said, it could be nutritional interventions, it could be psychological interventions, it could be values-based decision-making, cognitive behavioral therapy, it could be sleep or stress or medications or all those things. So it's looking at the person in the context of their life. So this is not about bombing somebody's life where you need to quit your job, you need to move to the countryside, you need to be up and down the mountain 7 times a day, meditating 6 times a day. Like, that's not practical. This needs to be a treatment that fits within the confines of somebody's life, within their kind of, you know, the financially,
their budget as well,
their kids, you know, everything else. So behavioral, I suppose, is what people will be most kind of familiar with, because they might have tried some elements, but maybe they haven't done it in a structured way. Okay, so behaviorally, I think conceptually of kind of keeping our eyes on the road. Okay, if we talk about the biological treatments, so if we talk about pharmacotherapy or medications or bariatric surgery, that works more on a biological basis of turning down the volume on the caveman, on reducing the biological drive towards food. So we have a number of different medications that are licensed in Ireland to help people manage weight. Okay, there are 3 medications for weight management in Ireland. There is one called Orlistat, which has been around for many, many years, that does nothing in the brain. It purely stops us absorbing about 30% of the fat in our diet. If we don't take much or any fat in our diet, it will have absolutely no benefits to us.
Kind of gone out of fashion now. I see it very infrequently prescribed.
It should be.
Yeah.
It is the devil.
It isn't great. Sure, it isn't.
It's awful. So again, it's why it's awful is it does nothing for the subconscious brain. So the driver of all this, it purely, for some people, can create a calorie deficit by reducing our absorption of fat. Okay.
It can also cause awful stools and, you know,
and that's the biggest problem is people will come back and they won't continue on the medication. But it has been prescribed a lot and is available over the counter in a format as well. But if somebody takes a fatty food, by God, they'll pay for it. You'll get greasy, oily stools that are hard to flush, flatulence, leakage, and I don't know what the medical term for sharting is, but that would be kind of follow through, kind of the laundry.
I'll look that up.
We'll have to come back to that one. You can kind of dub it in maybe if you can find it. So Orlistat is a medication that's out there. I rarely use it. Okay. So the second medication we have is a combination oral medication. The brand name is Mysimba, and it's a combination of 2 older medications, one called bupropion and another one called naltrexone. So bupropion, as you'll be well aware, was initially developed as an antidepressant medication. Wellbutrin was one of kind of the brand names in the past. We've also used it for helping people stop smoking under the brand name Zyban. But it works on kind of the reward pathways in the brain to change the chemical reaction we get in the limbic system and the reward pathways. So as a result, we get less craving, wanting, kind of desire for certain foods. It also has an impact on kind of some of the hunger centers in the brain. They've combined that medication with another medication called naltrexone. So naltrexone is a morphine or opiate receptor blocker. So these receptors in our brain that morphine works on, there's a crossover. Food also has an impact on some of these morphine receptors in the brain. So by blocking some of those receptors, we get less of that kind of craving, wanting, kind of reward drive towards food. Because if we think about kind of, you know, the body hunger, the kind of hunger and fullness hormones, and then people talk about this hedonic or kind of reward-based decision-making as well. So both of those areas are impacted by this medication. It's a tablet that people take every day. They start off on 1 tablet a day for at least a week, and then they go up to 1 in the morning, usually kind of 1 later in the day. Next step is 2 in the morning, 1 in the afternoon, and then 2 and 2. So 4 tablets a day is the usual kind of maximum dose.
How do you find people get on with that?
There are many people who can't take it because of medical issues. So if somebody has a history of uncontrolled blood pressure, if they've got severe kidney or liver disease, if they have a history of bipolar disorder or bulimia, if they have had seizures in the past, then this medication is not suitable for them. If somebody's on opiate medication, so strong painkillers, it's not suitable for them either. From a kind of a side effect point of view, the challenges, kind of intestinal side effects are not uncommon. Some people, there can be a slight increase in blood pressure. Now it's very, very small, slight, but it needs to be kind of monitored. And then for some people, it can have an impact on anxiety. And the biggest actual kind of issue that I find, and one of the reasons why we don't use it as much, is insomnia. So insomnia can be one of the more difficult side effects. And again, I'm acutely aware in the people that I see who might already be kind of dealing with issues with sleep, if they're dealing with perimenopause or menopause, the last thing I want to do is add to that.
I know, And also, like, it's not available on the medical card or the drug payment scheme, which is...
That is a problem with all of these medications. I know. They are not reimbursed, they are not covered. And it speaks to the way, you know, payers or the government think about kind of treatment.
I have a huge issue with it. Huge
and don't get me started. And this is one of the issues I chat about every day, because, like, again, it adds to the stigma. This is your responsibility. Sure, why would we need a medication?
Why would the taxpayer pay for your, you know, fat injection? Really, isn't that
exactly? And that's a major concern, because again, we know from a health point of view, kind of long term, the benefits that will be seen. You know, but you know, I think and I hope in kind of 40 years' time, it will be unacceptable for doctors and healthcare professionals not to address weight. In the same way as, like, somebody comes into me and they had roaring high blood pressure, like, it would be medically negligent of me not to address that and treat that and offer that person treatment. Whether, now, if they don't want to take the treatment, that's absolutely fine. We're all the masters of our own destiny. It's, you know, it's for each individual to decide what's right for them. But, you know, it will be, I hope, medically negligent not to talk about weight in the right way and not offer treatment in the future.
I hope we're not waiting 40 years for it.
No, but I'm kind of just seeing how kind of slowly things have changed. Now, I think things have accelerated in recent years, probably because of new treatments becoming available. And I think the third type of treatment that is licensed in Ireland, these GLP-1 medications, that is probably the future, and that is offering the most hope for people.
Yeah, it really is. Do you want to discuss what they do?
So GLP-1 essentially is a gut hormone that we all produce. Okay, so if I eat something, after I eat, my small intestine produces this GLP-1, glucagon-like peptide 1 hormone. Okay, and that hormone communicates with my brain to tell me I'm full. It's a fullness hormone. So in studies, they have shown that those of us who have an issue with our weight, we either don't have enough of this hormone or we're not getting enough of a response from this hormone. So by giving somebody a medication that is very similar to this hormone, that acts like this hormone, it communicates with that part of my brain that regulates kind of appetite and regulates kind of fullness, essentially to make me fuller quicker with less food. So rather than being kind of appetite suppressant, it's more of a fullness effect. So people come back to me and they would say, you know, I'm not thinking about food as much. I feel fuller quicker. I can still eat and enjoy food. I just don't want as much of it. I'm not thinking about it. I don't get the same cravings or wantings. And it's really interesting, because then they'll say, you know, I'm not dieting. I'm not restricting myself. I'm just not as bothered by food. And this is where people come back, you know, they say, for the first time in life, I know what it feels like to feel full. You know, and the mental freedom they get from that. So again, this medication acting on the caveman subconscious part of our brain to reduce kind of our drive towards food, we feel fuller quicker with smaller amounts, less craving and more full. So this medication, the way it works, it can't be taken, there is a form that we take orally, but it is not as effective to manage weight. So it's an injectable medication that people take underneath their skin. GLP-1s were first developed years ago for the treatment of diabetes. So independent of their effect on weight, these medications are fantastic for helping regulate insulin production, for insulin resistance and controlling blood sugars. Independent of weight, there is benefits to blood pressure. They're looking at it, whether there's a benefit to fatty liver disease, and potentially there are studies ongoing looking at the potential protective effect on the heart as well. So metabolically, there's lots of GLP-1 receptors around the body that kind of this medication acts on to have benefits to the body. So in its, when I eat, I produce this hormone, it goes to my brain. In its natural form, it lasts about 90 to 120 seconds in our circulation. So it's gone fairly quickly. So that's why I can be eating, I might feel full, I stop eating, and then I get a second wind. Dessert comes and I can now eat dessert again. I found a second stomach because my levels of fullness hormones have reduced because it's very transient. So when somebody's on this medication, not only do they feel fuller quicker, but they often have a more persistent or preserved fullness. So again, they're less inclined then maybe to kind of snack after food.
And it's a once a week injection as well, isn't it?
So there's two forms kind of that are licensed. One called liraglutide under the brand name Saxenda, and that's the one that's been licensed in Ireland and available for quite a while, and that's a once a day injection that people take. Okay. There is another medication called semaglutide, and this is the one that was kind of in the media recently. It's been licensed in Europe under the brand name Wegovy for the management of weight. The challenge is Wegovy, or semaglutide, the generic version, but Wegovy is licensed in Ireland, but it's physically not available in Irish pharmacies yet. And it's likely to be probably start to middle of next year before we actually physically have it here. It's available in the US, but it's not available in Europe yet.
And do you know why that is?
It's a shortage worldwide. Okay. They can't produce the stuff fast enough, and the delivery devices, they can't produce enough. So they haven't got enough of it, and it's showing to be effective in the US, and they're using kind of huge amounts, so there's not enough left for the rest of us.
It's also going through, in Ireland, I think, pharmacoeconomic studies to see if the cost-benefit analysis is worthwhile. Although, like as you say, it's licensed here, it's licensed privately, not on the public system, isn't that right?
So I think if we look at licensing means that the company has applied for kind of a license to use this or market it for a certain medical condition. So some medications might be licensed to treat diabetes. They might also be very effective to manage weight, but they don't have the license for weight management. So licensing is kind of one thing. We use medications on license and off license in Ireland and across the world. Again, but it requires kind of discussion. So kind of semaglutide under the brand name Wegovy is licensed. Actually, Saxenda, the liraglutide that I did mention again, went through kind of the pharmacoeconomic kind of studies as well, and was shown that there was a benefit, and there is a hope that will be approved and covered under some of the payment schemes, but it'll probably be prioritized for people with pre-diabetes or heart disease, those people who have more of a profound impact on health from weight, because economically and kind of from a health point of view, they're the people who will probably benefit from it most initially. So they're the people who may kind of maybe reimburse for first. So
and by default then the hospital system and the healthcare system in general, because if those people are looked after and their health is improved because they lose their weight, it means that they won't have as many hospital appointments if they're diabetic. It feeds into the system.
Absolutely, and kind of long term, it's going to be beneficial. The problem is a lot of kind of people are not looking at the long term picture, particularly kind of on the payer side. It's about budgets, it's about kind of now, and there is a concern that because these medications can be so effective, and like we said, if there are 60% of the Irish population who kind of may have some issue with weight, there's a concern that kind of a lot of people will be kind of using these medications and the cost of the exchequer. But again, if you look at the long game, these medications, like I said, this is not about the cultural desire for thinness, it's about health, and we know for some people they can have a significant impact on health.
So we did discuss there about BMI being, a ridiculous kind of marker for health and weight in general. However, the Wegovy is licensed for people with a BMI over, a certain amount, over 30 or else over 27 if they have an underlying illness. So how do we then decide who gets it and who doesn't?
Yeah, and that's, I think in all the studies, they kind of use these kind of metrics. So even though I'm kind of saying, experts in the field are now moving away from BMI, we're not using it as a diagnostic tool, we're not kind of using it to define health. Still in the studies and the licensing, these are still there. So like you said, GLP-1 medications that are licensed for weight management are licensed for people with a BMI greater than 30 or greater than 27 with a weight-related medical issue like blood pressure, cholesterol, diabetes, fatty liver. And that's kind of what the license says. So again, there are many medications that are prescribed on license or off license, but that's kind of the guidelines and the recommendations. Again, for me, it comes down to health. If somebody has a negative impact on their health, whether that's psychological, functional, or metabolic health, then I'll often offer treatment to that person. So again, it's very individualized. Just because somebody's a bigger person doesn't necessarily mean they have to or should go on these medications. Again, a lot of kind of when we're talking about these as well is managing people's expectations of what's going to happen with these medications. I think increasingly we're all, privy to these kind of before and after photos, body transformation photos, the person who had surgery or went to medication and had a phenomenal response to them. And some people will seek treatment with the expectation that that's what's going to happen for them. We know with these medications, it's a very variable response. So if we look at GLP-1 medications, really in practice, I would find probably 50% of people get a good response to them. 50% of people don't respond as well. Okay? So it's toss of a coin. And
yeah, I've seen that too, where people thought it was the magic bullet and it did nothing.
Yeah. And we, as somebody who likes to think kind of they know a few things about this area, I and all of my colleagues, no matter how expert we are useless at predicting who's going to respond and who's not going to respond. So it's often a trial of treatment to see if somebody responds or not. And when I say respond, I mean kind of a biological response. If somebody comes back to me and they say, I'm less hungry, I'm more satisfied, I'm not thinking about food all the time, I know what it feels like to feel hungry, my relationship with food is better, that person's having a biological response to the medication. They are not dieting, they're not restricting, they're not trying to take in less. They are naturally, without effort, so this should be effortless, almost passive, taking in less.
Yeah.
It's not that they're trying any harder. There might be another person who comes back who's taking the medication and they're not noticing those changes in their appetite system. That person is not doing anything wrong. It's just that the medication is not addressing their biology. And I am very firm on the fact to people that across medicine, across healthcare, people do not fail treatment. Treatment fails the person. So if somebody's not responding, they're not doing anything wrong. It's just not the right treatment for them. The problem is we don't have as many medications for this medical problem yet as we have for other medical problems. So, if I'm treating somebody and they've got high blood pressure and I put them on a blood pressure tablet, one person may have a miraculous response to one tablet, whereas other people will need 3 tablets, to manage their blood pressure.
Yeah.
Or still have an issue. Same with asthma, same with kind of cholesterol, any medical issue. So the way I treat weight is the same way as I treat any other medical issue. This is not any more important or less important than other medical issues. It's just another medical issue. But we need to have this chronic disease kind of management approach of this is lifelong. And that kind of brings...
So someone needs to be on these medicines, like it's not a case of they can take it for a certain amount of time, lose the weight or become healthier for that period of time and then go off it. It is lifelong, yes.
And this and the reason I'm smiling is because this is the question that's asked to me every single day. We are all conditioned to think if I just get my weight down, I'll be able to keep it there. Based on the studies, that is not the case for the majority of people. So this is not like taking a course of antibiotics that we're curing the infection and it's gone. This is chronic disease management. This is lifelong treatment in some way, shape or form. So let's say I have high cholesterol because of my genetics. Okay. And I go to my doctor and the doctor recommends I take a cholesterol tablet or a statin and I take that tablet and I have a follow-up blood test and my cholesterol comes down. While I stay on the medication, my cholesterol will be well controlled. If I stop the medication, it's common sense that the cholesterol will go back up again because the medical condition is not controlled anymore. The same is the case for weight. When we start on these medications, generally initially, a lot of people will notice kind of a reduction in weight and they may notice it kind of faster at the start. Usually at kind of 6 to 9 months into treatment, we will see a plateau. That at any given intervention, our body will not let us continue losing weight forever, so our weight will plateau. And that plateau is going to be different for everybody based on our genetics and our biology and our life experience and so many different factors. And it's not something that's within people's control. We can look at studies and say kind of on average, this is the average response in the people who respond to the medication, but we can't predict for any individual what's going to happen. And you will have some people who have a very strong response to the medication and you will have people who don't respond to the medication and they're not doing anything different.
And what option do those people have then? Because they must be very upset if they've got to the stage where they're on the medication and it doesn't even work for them.
I think, and that's why it's important that we're not selling magic beans here. We're not telling everybody this is the cure.
Yeah.
And my concern around these medications is perhaps, if somebody doesn't kind of, get these medications from a source that can educate them, that can monitor them, that can talk about kind of the expectations. So let's say, somebody is getting this prescribed as kind of a diet, a quick thing.
Or not even prescribed. There are salons that are selling these medications. I don't know how they're managing to do it.
I have had patients come to me who have gotten them through those, and again, you talk to them, and there are medical reasons why certain people shouldn't be on these medications, and that hasn't been kind of properly gone through. So this is a prescription medication. This is not kind of a quick fix. It's not an lose weight before a wedding, or lose weight before kind of rugby season starts, because
people want to use them for that, though. That obviously.
Yeah. Oh, absolutely. And again, I'm acutely aware. And I talk to people, a lot of people would say to me, but I don't want to be on this long term. And again, I suppose I see my role as kind of making it absolutely barn door clear from the start that this is long-term treatment, that the response is variable, that in studies, this is where kind of people are likely to end up. So, again, people are smart. People are kind of, make decisions for themselves. But if we can kind of, give people the information, then they decide what they want to do. But, these medications will work for as long as we take them. If we stop the medication, our weight will go back up to where our kind of set point, our thermostat in the brain is set. So this is long-term treatment that will work kind of as long as we take it.
And then bariatric surgery being the next stage, I suppose, if someone isn't responding to that, or if they've reached a plateau that they're not happy with. What are your thoughts on that, and its availability or inavailability in Ireland?
Yeah. So I have lots of thoughts, again, on all of these things. Bariatric surgery is an absolutely fantastic treatment. It is safe, it is effective, it is evidence-based. Okay.
And what does it do?
So basically, I suppose if we're talking about the two kind of two major kind of surgeries that are done, so sleeve gastrectomy or gastric sleeve is one, and gastric bypass is the second. So sleeve gastrectomy, a certain portion of the stomach is removed, whereas a gastric bypass, essentially the plumbing is changed, where the stomach is kind of plugged out, and there's a reconfiguration of the intestinal tract. These medications predominantly do not work by just restricting. So it's not that we're giving somebody a smaller stomach that they'll get sick if they eat too much. Okay, which is one of the big myths that's out there. These medications work by changing the anatomy of the intestinal tract. We have an effect on the hormones that communicate with the brain about hunger and fullness and appetite. So all those hunger and fullness hormones I talked about, they come from the stomach, they come from our muscle mass, our fat mass, our pancreas, they come from the periphery, and they communicate with the brain. So by changing the anatomy of our intestinal tract, we change the levels of those hormones. So as a result, people are less hungry, they're more satisfied, and they crave food less. So that's how kind of bariatric surgery predominantly works. Now, some of the surgical procedures also contribute by kind of reducing absorption of certain foods or kind of nutrients as well. There can be a change in our bile acid kind of production, which has an impact too. There can be a change in the microbiome, so the kind of the bacteria that are in our gut as well. So all of these different things contribute to weight coming down. And again, response is variable person to person. But bariatric surgery is probably the most effective treatment we have. The problem is, exactly as you alluded to, the availability. That in Ireland, it is limited, we are restricted, and really it's reserved for people who are more severely affected by weight. Okay, so in my view, it should be made available sooner, it should be made available earlier, and it should be a treatment option. But, it's a case, I don't think about this as like a pyramid that kind of, behavioral intervention is the bottom of the pyramid, then we have medications, then we have surgery. We think more of this as kind of a continuum. So when I talk to people, I will say there are three types of treatment that are available. There's behavioral intervention, there's medication, and there's surgery. Here are the pros and cons of each. Here is the expectation of what's going to happen with each of them. Here's the side effects and benefits. And then it's up to each individual to tell me what is right for them. So the days of the doctor being this kind of paternalistic telling you what to do, that's dead and buried, thank God. People are educated, they are smart, they often know more about their own body and their own health than I know.
Of course, yeah.
So people are coming in, they're educating me on kind of medical conditions as well. Because again, this affect them? It makes absolutely no difference to me whatsoever what treatment somebody follows. It's not my life, it's their life. So they might say, well, medication is acceptable to me and I will take that and I want to pursue that. I want to do that with a behavioral intervention, which is fantastic. Or they might say, no, I think surgery is right for me, and they'll do that with kind of support. So one of the challenges is obviously because surgery is limited in its availability in Ireland, both publicly and privately. Like obviously the weight management clinic in Loughlinstown is absolutely fantastic. It offers an amazing service and kind of follow up for people, really multidisciplinary, kind of cutting edge stuff. But the number of patients they can kind of treat is limited because of the resourcing.
Yeah.
So, there has been, I'm on the clinical advisory group for the obesity program in Ireland, and there has been a model of care for obesity kind of developed to try and increase the availability of treatment. But that has to be adequately resourced and kind of instituted so people can access treatment. So because of the limits on kind of who can access treatment, because of the limits on the availability in Ireland, then, as well as that, we're acutely aware of lots of people going abroad to have surgery. And you can totally understand why people do it. People are desperate for treatment.
Of course.
And they see other people who've had treatment and they go abroad. The surgical procedure usually will go okay over there. There is a percentage of people, a small percentage, maybe 5% of people, who will have a significant kind of complication, either kind of surgical or post-surgical or some issue with bariatric surgery. But the vast majority of people, it's a very safe operation. Like the complication rates after bariatric surgery are somewhere the same as kind of having your gallbladder taken out, which we think of as a much more kind of routine surgery. But bariatric surgery it's a lifelong treatment. It's not just kind of, you have the surgery and you're done. Like it requires taking kind of vitamins and minerals lifelong. It requires blood tests. It requires psychological follow-up. It requires like checking bone density because of change in fracture risk, screening for addictions and other issues that can arise. So it's a lifelong treatment and people need to be supported.
Why can the addictions arise?
I don't know what the kind of rationale, presumably it is to do with the kind of reward pathways in the brain. And it's not, again, this is not something that will affect everybody.
Yeah.
But again, it's something that has been noticed in studies that the rates of certain addictions can increase after bariatric surgery.
Okay.
And again, it's a case of, some people, might be losing weight, but that's not the only thing. Again, nutritionally, we need, people need follow-up. We need to make sure they're getting adequate protein, adequate fiber. We need to make sure that they're kind of, being physically active and protecting their muscles. So none of these treatments in isolation. So the same with kind of the medication. It's not a case of here's a medication, good luck and good night. Again, I would see bariatric surgery and the medications as a tool that facilitates behavior change. So by being on treatment, by shutting up the caveman, I'm obsessed with this caveman.
That's fine, it's a great analogy.
By doing that, it facilitates the smart person who knows the decisions they want to make, who knows about nutrition, making kind of good choices. So these facilitate us changing our behaviors and changing our life long term. And, but they're not without issue. Again, some people might encounter weight regain after bariatric surgery. Can you imagine going through that treatment and kind of all that involves and kind of, making that kind of very brave decision to seek treatment and then encountering weight regain? Again, and again, that kind of knock of the stigma coming back again, and people blaming themselves that they've done something wrong. But it just speaks to how complicated weight regulation is in the body,
and how difficult it is to get it off and keep it off. And then also with the bariatric surgery follow-up, and quite possibly with the other treatments that are available, is people's body shape changes and they have lots of loose skin. Does that require then cosmetic surgery down the road to clear that up? Like, I mean, it's kind of seems to be an awful lot for someone to go through, doesn't it?
And that's, well, I suppose that's why this is kind of a multidisciplinary long-term follow-up, because different people will have different challenges. Now, again, if we look at kind of bariatric surgery and how within days somebody their diabetes might go into remission, the benefits of kind of the health gain that people can see with these treatments is phenomenal. So, people are coming off medications, they're becoming more active, their quality of life is changing as a result of being on treatment, whether it be, behavioral medication or surgery. People's quality of life and their health is improving. But again, there are going to be challenges. There are going to be issues kind of, down the line that they have to navigate. And it's to make sure, that's where we talk about kind of chronic disease management. It's to make sure to support people through these challenges, to help them navigate, the challenges. So again, kind of with medications, we talk about kind of, weight plateauing. And we talk about kind of, that where our weight ends up may or may not be where we want it to be. And again, where we want it to be for health reasons or not. So if we look at kind of, each of the treatment options, if we look at kind of behavioral interventions, internationally kind of with the kind of best of behavioral interventions, we'll see maybe a kind of 5 up to kind of 8% change in body weight. Okay, body weight reduction. With medications are advancing and developing with the currently available medications in people who respond. So if we take the 50% of people who respond to the medications, on average, we're probably seeing a 10 to 15% reduction in body weight.
So that actually isn't huge when you consider that someone might be very overweight. But I like the look you gave me there. You're like, what does that mean, Laura?
It depends what our marker of success is.
Okay.
So if our marker, and that's why these are not treatments for the cultural desire for thinness. These are treatments for health. So if we talk about health, 10% change in body weight seems to be the line in the sand. It seems to be the magic number. If somebody kind of is managing their weight and they have more than a 10% reduction in body weight, that has phenomenal effects on health. Our risk of diabetes, our risk of kind of blood pressure issues, reducing, treating sleep apnea, fatty liver, acid reflux, function, pain scores, mobility, quality of life, sleep, all of those things improve phenomenally. Some of them will start improving at 5% reduction in body weight. A lot more we will see at 10%. And there are some medical conditions that kind of, higher percentage of weight loss will have even more effect. But we used to talk about 5%, now we're talking about 10% and even kind of 15%. So 10% reduction in body weight, will it have us at what is put out there as a normal or ideal body mass index? No, it probably won't. Will it significantly improve our health? Yes. Will we live longer? Will we enjoy life better? Perhaps. So again, that's kind of the marker. And again, people come to me and they're not weighed and they're saying, what weight should I be? And I said, I don't know what weight you should be. It's because you're different, you're unique, I've never met you before. Your weight is a function of your genetics and your biology and the life that you've had and the dieting you've done and the issues you've been through. So I don't know what kind of an ideal weight is for any individual person. And I don't work off a target weight or an ideal weight. So again, But you
need to change the thinking then, isn't that it really?
So, my thinking is different. And I talk to people about this and they're looking at you as if you've got two heads. Like that this is a different way of thinking about it, but this is the way we should be thinking about it. Obviously, I think I'm right about pretty most things, but this is what the evidence and science tells us.
Okay.
So we talk about this idea of best weight. And our best weight is the weight we will be when we are living our healthiest life that we can enjoy and sustain long term.
I think that sustain long term is really important because you can enjoy it for a certain length of time, but the sustainability of it is another factor, isn't it?
And again, it's a case of, if we apply an evidence-based intervention, be it behavioral, medication or surgery, as a result of that treatment, weight will come down. And no matter what treatment we apply, we will eventually plateau. Our body won't let us continue losing forever. And the weight we're at, if that's where is sustainable, enjoyable, and we're balancing the values in life. Because life is a balance of pleasurable experiences, family, socializing, nice foods, but also health and long-term kind of longevity and avoiding disease. So it's getting that balance. A lot of people and most people who've been on diets, they have kind of lost weight, but again, they're not getting, it's not sustainable because it's not enjoyable and it's not long-term, how they can continue living their life. So somebody can drop their weight plateau further, but they might be absolutely miserable doing it.
Yeah.
So what's the point?
Yeah.
Again, this is about our best weight, the weight that we are when we're living our healthiest life. Yeah. And also, every person responds differently. So one person's response to treatment is going to be different from another. And that's not their fault. It's not something they can control. So all we can do is apply the most evidence-based treatments, and then our weight is going to end up where it's going to end up. And that's not within our control as much as we would like to think it is.
Yeah, it's interesting that, isn't it? Like you say, it's not as within our control. We can't just keep losing weight and get to that size 10 that we're told is the ideal way to be.
People say, I just want to be kind of the weight I was at this point in my life. And they might equate that weight with, happiness or whatever was going on at that time in life. Even if they were to get to that weight, it doesn't necessarily mean their life will be like it was, in the past. Or, I want to get to the weight I was in school, or I want to get to the weight I was when I got married, or whatever it might be. Again, we have this kind of idea in our head that if I can just control my weight and get to that point, my life will change. And I think again, that's because of the way we're conditioned to think about weight being the cause of and solution to all the world's problems. It's not.
You mentioned marriage there. We see an awful lot of ladies in the run up to their wedding going on, monstrous diets where they're, I attended a wedding that the lady, the bride nearly fainted. She was so faint from actually starving herself prior to the wedding. So, and that's that unhealthy attitude that we have. We need to look absolutely amazing for that one day. It is just that, and it's that constant bombardment of the bride on the day, and she's the most amazing she's ever looked. But in actual fact, she's not herself. She's not healthy. So it's about changing that entire conversation around your best weight, your best healthy weight. Isn't that right?
Absolutely. And I think a lot of people that I meet, again, we'll talk through their history and kind of, it'll be very much that their weight change over time has been driven by different events in life. So they might have a goal in mind. Let's say it's a wedding, or let's say it's graduation or going on a holiday. They have a goal and that's what they work towards, and they can do very, very restrictive, very unpleasant, very unhealthy, unsustainable things to get to that point. And there's a kind of a destination. They get to that destination. So we get to that destination and we get through the day, but the things we're doing are not sustainable. And again, psychologically in our head, we get to that destination and it's finished, it's done.
And then the wheels come off.
Yeah, but this is not a destination, this is a journey. Mm-hmm. So this is not about getting to a certain point. This is about all we can do is do our best day to day, every single day. And there are some days it's going to be easier and there's some days it's going to be harder to manage our weight. Let's say, God forbid, I have a family member who's in hospital and I'm with them in hospital and I'm not in my own environment, I'm not in my own routine, there's only certain foods available in the canteen or vending machines. It may not be possible for me to eat the healthiest way I can to manage my weight at that time. But that's okay. All I can do is do my best. Other things have kind of superseded and are more important. There are other things that are more valuable at that point in my life, and I shouldn't beat myself up about it, because I have other stuff going on. So it's a case of, all we can do is do the best we can day to day within kind of, what we're dealt with in life. But if people are properly supported, if they're properly treated, then that offers kind of the biological protection.
And then just on the prescribing of those drugs as well, I've, a lot of people messaging saying they've asked their doctor's reluctant to give it to them, even though they feel they need it. And is it a case where, people have to go to a specialist or an endocrinologist? I in the pharmacy anyway, I only had one person on Saxenda, and it was an endocrinologist that had initiated that, and they had to keep going back to the endocrinologist for it.
So the challenge is, I suppose, there is a mistrust of some of these medications from healthcare professionals. A lot of that is based on previous medications that were around for weight management that were more on the stimulant side of things. Mm-hmm. And those medications were then shown to cause cardiac issues and heart valve issues, and they were taken off the market. And there's a bit of it's a bit like HRT. There was this big scare about health around HRT, and it totally muddied the waters. So some doctors then, are reluctant to prescribe these medications. I think a lot of us, and I've just kind of, talked about how I didn't feel well educated, I didn't feel well prepared or skilled in having these conversations. And if you look at kind of the barriers, kind of from the healthcare professional point of view of talking about weight, the three big things that come up in studies are, concern about offending people, lack of time to talk about it, and the kind of lack of resources. So, doctors are not kind of reimbursed. They don't feel educated enough. They don't feel sometimes kind of skilled enough to have those conversations, and they're worried about offending people. I'm, incredibly lucky. People are coming to me to talk about weight. So I'll ask them permission. Is it okay if we talk about weight? And they look at you, of course, like I'm here to talk about my weight. But in a general practice or in a hospital, it's more challenging kind of to bring up those conversations sometimes because it's, it's not always appropriate. To bring up the conversation about weight, but it's kind of, opening the door to talk about these things. So some doctors, I think, and again, the weight bias that exists in society also exists in healthcare. Some doctors might, sorry, I don't mean to, purely pick on doctors, but I can slag them off because I'm one of them. But you can say any healthcare professional, whether it be my nursing colleagues or physios, pharmacists, any healthcare professional. Again, we think about weight, or they think about weight in often a very stigmatizing, biased way. So again, they think, if somebody's looking for kind of these treatments, they're looking for the easy way out. They're looking for the quick fix, the shortcut. And my kind of response to that is, well, is it a shortcut or a quick fix to take an inhaler for asthma?
Yeah.
Is it a shortcut to have my gallbladder taken out if I have gallstones that are absolutely crucifying me? It's not. It is a safe, effective, evidence-based treatment. So that's the way we should think about these treatments. As far as we talked about kind of Saxenda being the once a day one, the challenge of that is cost. It's very significant, kind of the cost of the medication per month. We talked about Wegovy being the once a week version that is now licensed in Europe. Wegovy, so semaglutide, the generic version, we do have in Ireland for the management of diabetes at the moment. So semaglutide under the brand name Ozempic is used to treat diabetes in Ireland. It just doesn't have the license for weight management. It is exactly the same medication as Wegovy. So Wegovy and Ozempic are the same stuff, semaglutide.
And do you prescribe that?
Yes.
Yeah.
And again, it's as long as people gain an understanding, this is off license.
Yes.
We are prescribing you a medication for diabetes, even though you don't have diabetes. And I am comfortable and confident doing that because of the scientific evidence and the studies. The exact same medication is licensed, just under a different brand name.
I know. So it's people wrapping their heads around that
It's
issue.
been rebranded, even though it's the exact same stuff. Now, the difference between Ozempic and Wegovy is the dosing. At small, they both start off at kind of a low dose, kind of weekly for the first month, and then they go to the next dose weekly for the next month. And then the Ozempic will kind of max out at a 1 milligram dose. And that's kind of the highest dose that's available kind of in pens in Ireland, because that's the dose that has been shown kind of over the years to be the one that's kind of reimbursed for kind of diabetes. Mm-hmm. In the weight management studies, semaglutide at a dose of 1.7 and 2.4 milligrams has been shown to be even more effective. And when Wegovy comes along, it will go in the same kind of dose escalation, but will go to a higher level. So if kind of at the 1 milligram kind of Ozempic semaglutide dose, we're seeing on average in the responders a 10 to 15% change in body weight. At the higher doses, 2.4 milligrams, we're probably seeing a 15 to 20% reduction in body weight. And that's why those of us who kind of are interested in this area start getting very, very tingly and excited about this, because for the first time ever, we are seeing with a medication kind of changes in body weight that are approaching kind of bariatric surgery levels of weight management. And over and above that, we are seeing the health benefits to people that can deliver. We are seeing the benefits to kind of their psychological health and well-being as far as relationship with food, kind of internal stigma and bias. We're seeing the functional gains people are having, and we're seeing the metabolic gains people are having. And that's why this is such an exciting time. So, we haven't even got Wegovy, that branded version here yet. And we're already talking about the next one.
I know, it's crazy. The amount of questions that I got in about it, and even people going into the pharmacy about it when it was, they announced it in the newspapers without it bloody well being in the country, and we're, having to feign off all the questions. But what are your thoughts on metformin? It's used sometimes, but not very frequently.
Yeah, so metformin is an oral tablet obviously used for diabetes, and it's been around for a long time, and it's a relatively cheap medication. It works really well when somebody's initially diagnosed with diabetes to kind of help manage that. It isn't a weight management medication. For some people, it is associated with some reduction in weight, but not to the level that it is considered a weight management medication. Some women will take it if they're living with polycystic ovarian syndrome, PCOS, because of the effect that metformin has on insulin resistance, which is one of the significant physiological things that's going on with PCOS. And for some of those women, it can have a more significant change in weight, as well as having an impact on regulating kind of their cycle and kind of period as well. So metformin is a useful medication for diabetes. It has value for polycystic ovarian syndrome. It isn't a medication that is a weight management medication. Some people may see a benefit for it, but I wouldn't be prescribing it for that benefit to people.
And can I just ask you as well, so we know that the Ozempic and the Saxenda and the Wegovy is for, certain people with a certain, what's prescribed as a certain BMI. But what are your thoughts on people taking it if they just wanted to lose a few pounds, or if they have that belly fat that they want to try and get rid of? Like, do you think it is an option or should be an option for people, or is it more that you would rather it stay within the
No,
people?
so it shouldn't be an option.
Okay.
It shouldn't be an option. That's not what it is for.
Yeah.
That's not what it's indicated for. And again, using it in that way is essentially just diet culture. It's just a new diet.
I know people flying over to Spain for it and getting it over the counter over there. They don't need a prescription for it.
That's just reinforcing weight bias, weight stigma. People who don't have a medical condition, who are just striving for a thinner body and aesthetics. We are, adding to disordered eating. We are adding to kind of eating disorders, and that's not what these are for. And they shouldn't be used for that. And again, that's my concern if people are getting these in other ways from somebody who is not familiar with the medication. So again, even the GLP-1 medications, we didn't discuss the fact that if somebody has a history of pancreatitis, they shouldn't take those medications. If somebody currently has gallstones, we need to be really cautious, and a lot of people, we won't use them if they currently have gallstones. If somebody themselves or in their family has a history of a rare type of thyroid cancer called medullary thyroid cancer, or a rare genetic syndrome called multiple endocrine neoplasia type 2, which is a genetic cancer syndrome, then we don't use these medications. Because again, these medications, other than cost, which is the most significant barrier we see in people paying for them, kind of long term, the other major kind of issues are, some people can have more severe side effects, some people are not safe to take them. So, when we use these GLP-1 medications, 1 in 100 people might develop gallstones when on the medication. Okay, so kind of long term. Now, anything that causes weight loss can cause gallstones, but over and above that, there's a 1 in 100 risk of gallstones. So if somebody currently has gallstones, we might aggravate their gallstones. They might get complications, cholecystitis. They could get jaundice. They could get pancreatitis as a result of the gallstones. So that's not insignificant. And people need to be counselled on that risk so that they're aware of kind of what they're kind of letting themselves in for. As far as pancreatitis, if somebody has had a history of pancreatitis in the past, then we don't use these medications, because it's a concern about re-aggravating that. If somebody hasn't had that history, there's a between 1 and 3 in 1,000 risk of developing pancreatitis. So it's rare, but for the person it happens to, it can be a major significant health issue.
Yeah.
The thyroid cancer one is a bit more strange. As I'm sure you're aware, in the preclinical studies, when they tested this stuff on rats, some of the poor rats got thyroid cancer. Okay. When they tested it on monkeys or simians, I don't know what the politically correct term for them is, but when they tested on monkeys and humans, in the weight management studies, there was no cases of that type of thyroid cancer. And because these medications have been around for diabetes for many, many years, they've kind of been monitored and tracked. There has been exceptionally rare cases of those types of cancer turning up, but they don't seem to be hugely over and above the risk in the rest of the population who are not on this medication. But again, people need to have this explained to them. Because really, again, it's case, and I have these conversations, and some people would say, "Okay, thanks very much for the information. It's not for me." And I say, "Brilliant!" Like that's.
How long do your consultations last? Because
so when I see somebody initially, we do a 40-minute visit.
Yeah,
and I'm not able to do it any quicker than that.
Yeah, I can imagine.
I'm not able because again, and as you've probably seen, I love to talk, and once you wind me up, I'm off like a shot. But I really, really think, number one, it is vital that people are listened to, that we kind of share an understanding of their lived experience and how weight is or is not affecting them. And it may not be affecting them. They may just have the cultural desire for thinness. So again, it's to tease out, what is their marker of success? What is their single most important outcome from treatment? What do they want? Do they want, is it health driven? Is it numbers on the scales? Then it's talking about kind of, the biology and the science and sharing that and why that might contribute to their issues. Then it's talking about treatment options that are available and whichever option they want to talk about and the pros and cons of each and the cost and everything else. And then it's for them to tell me what they would like to do. So again, like I said, I see my role as putting out the information, and then it's for them to tell me what they feel is right for them. Like I'm not the gatekeeper. I'm not the kind of, the sitting up on my pedestal saying you can have it, you can't have it. It's for people to tell me what's right for them.
Yeah.
Now I might kind of recommend to somebody that, based on kind of what we've chatted about, I don't think this is a good option. Medically, I wouldn't be happy to prescribe it in this situation because obviously I'm a medical doctor. I mostly focus on medications and the behavioral approach, and we have a nutritionist who kind of does some of the behavioral intervention too, as well as me. We have exercise physiologists because we know that, and that's the other thing that I think is important for people to realize is exercise is the greatest intervention for health. We will live longer. We will avoid disease. It is the most vital thing we can do in our lives. But in isolation, it is useless at managing weight.
Is it that 80-20%? Is that real, that number? You know, they say it's 80% diet, 20% exercise if you want to lose weight, or if you want to...
So as far as weight management, exercise doesn't cause weight loss in the vast majority of people. But again, and I need to really be careful in framing this, I'm not telling people not to exercise. What I'm saying is do it, but know the reasons we're doing it. We're doing it to feel better psychologically and physically. We're doing it to live longer. We're doing it to preserve our muscle and change our body composition. We're doing it for our metabolism. We're doing it kind of, for our long-term health. But this idea that we can kind of exercise and burn X number of calories, and on these calorie tracking apps, they've told us we've earned this amount of extra calories. That's not the case.
Yeah.
Our body is too smart. Again, the caveman couldn't be chasing, Christ, I don't know what they were chasing, buffalo or whatever they were, elk or maybe something. Whatever they were chasing, they couldn't afford to expend more and more and more energy. So there's a fantastic book called Burn by an evolutionary anthropologist in Duke University in the States called Herman Ponzer. And it's a brilliant read because it goes through kind of, again, a lot of those misconceptions and kind of exercise and how our body actually has this kind of constrained kind of energy expenditure model that we will burn calories at a certain level, but our body will kind of limit the number we burn. And then in the days following it, we'll try and recoup and regain those kind of that energy elsewhere through kind of, optimizing, our metabolism and kind of changing our energy consumption.
Isn't it crazy the way the body works? Like it's miraculous, really.
It's exquisitely designed. And,
yes.
and I talk to people, I'm a great man for analogies, and on top of my caveman little one, I talk about a polar bear. And people look at you as if you've got 10 heads. But I talk about a polar bear. Like a polar bear is exquisitely evolved to survive in a very inhospitable environment. They have black skin because of the sun, and they have certain distribution of weight, and their metabolism and, their paws and their anatomy is all designed to live in, the Arctic or Antarctic, and that's where they thrive. If you take a polar bear and you lift him up and you plonk him down in the middle of a desert, middle of the Sahara, all those things that previously protected the polar bear are now his worst enemy. All those things are now killing him. So essentially humans are a polar bear in a desert. We evolved to survive in a world where food is scarce. We now live in a world where there is the availability, the types of food, and many other factors that are contributing. So that's why, people say, oh, you're saying this is genetic. Well, why did my great-granny not have a problem with weight? They lived in a different world.
Yeah.
They might have had the genetic predisposition, but they didn't have the environment that facilitated that.
And really the environment that's facilitated this has only really occurred in the last, 100 years. So it isn't as if we're any time soon going to evolve the other way where our genes will want us to lose weight.
If you look back through history and if you look through kind of art and kind of the Romans and the Renaissance, there has always been bigger people. And again, that has always been the case. And even kind of culturally, it's really interesting to look around the world, to look at the perspective on weight is not all the same as it is here. I have colleagues who work and live in Africa. And again, kind of, weight is associated with affluence, is associated with income. You're successful if you're carrying weight. So again, it's interesting the difference there. But in our Western society, and even you see over the last kind of 20 years, how kind of, things have changed and evolved. There was kind of the age of the supermodel and this kind of, waif-like kind of, dangerously sick-looking kind of skinniness, to now the desirable body type is different. It's more athletic. It's more kind of, as you said there, kind of big bum, kind of small tummy. Like things change and evolve kind of with time, but it's not the same all over the world.
I wonder who decides why it changes as well. It's definitely something to do with fashion and that kind of like continuing the recycling of, okay, so body type A is actually great now, but let's in a few years' time we'll want the waifs back again. But my concern there is the whole so social media can be great in one way, and then in other ways, it can be very damaging. So even children from a young age now, they're being bombarded with these images. So say my children from even very small, we're talking about 6-packs. Like I wouldn't have known what a 6-pack was at their age. And they're being bombarded by this diet culture as well, where tracking calories is almost okay. It's the norm. Let's watch our food. Let's pump iron. So we'll, and what are your thoughts on that? it's almost like perceived healthiness where they're watching themselves all the time and they want to go to the gym, but then it's like a control thing too that can get out of control, and it can become something that absolutely absorbs them. So
yeah, and I think you're dead right. I think and it has always been there to some extent. Like if you look at like kind of, you'd walk into your GP's clinic and on the table there would be kind of, whatever magazine with your, top 10, tips to get the summer body, or kind of, the kind of different articles, the person who's had the body transformation and how they did it, and you can do it too. And, again, it's a multi-billion-dollar kind of industry, and it's fashion, and it's the weight loss industry, and it's now social media, and it's a case is, everybody's on a journey, everybody's kind of doing something, and we want to be like those people, but again, their response is different from mine. And then there's the frustration, the algorithms that are constantly throwing us up ads. Obviously we're on kind of social media, and you'd want to see the worrying stuff that comes up on our timeline as far as kind of, things people are doing to kind of manage weight. And again, whatever hope I might have with kind of the knowledge of the science and the evidence, the things that are being recommended, and people who potentially have little to no kind of, training, little to no knowledge, they're just working off, this is what I eat on a day to day.
Yeah.
Who cares what you eat? That's you. So that person potentially has no medical issue, has no weight issue. They have different set of genetics, different biology, not doing anything right. If I eat like you, I won't have the same body as you have. They have, again, genetics and biology. So this is more complicated. But again, we're everybody is striving for that. And I think it's again, there's a huge concern around that. And I know in recent years there has been kind of, and particularly over COVID, there's been a real increase in people presenting with eating disorders. And that is a huge concern. And anybody, I suppose, for me, and that's why this is not about weight, this is not about size, this is about health and focusing on that. And if I'm concerned that somebody might kind of, have issues with disordered eating, then that person needs extra support. That isn't not necessarily kind of my specialty or my area. So again, I would often kind of refer people, for psychological intervention, counselling. We'd often talk about BodyWise, the eating disorder kind of resources, and kind of encourage people to kind of seek treatment for those things, because there is also this idea that if you have an eating disorder, that's only thin people. There are many people who are living in a bigger body, who are living with obesity, who also have eating disorders, who have disordered eating. They might have binge eating disorder, they might have bulimia, they might have anorexia. Again, size doesn't tell us about kind of disordered eating or eating disorders.
And I think that's really interesting for people to know. But you said to me there that, it isn't a new thing, this whole diet culture. But I remember even when I was younger, there was this book called French Women Don't Get Fat. And it was about this French girl who had gone to America, and she put on loads of weight because of the way they ate over there, and she came back and they all called her fat. And she delved into this, why are all the women around me in France not fat? And it's because they're much stricter and they're very controlled by what they eat. But that kind of generalisation as women on the continent, like Italian and French women, would be a lot thinner than, say, Irish women. And they seem to be able to control their diet a lot more. Or is it a case of they control their diet until a certain age and then the wheels go off?
I suppose I think of it a little bit differently.
Yeah.
I think as, genetically, there's probably not huge, there's obviously going to be some variation, but not huge differences. But again, the environment that people grow up in, culturally, or the way we think about food, the types of food that are available, advertising, screen time, educational system, the subjects we study in school, smoking, whether people smoke or not, physical activity, it's very nuanced, and there's lots of kind of different things. Again, the healthcare system over there, versus here. Again, you could look kind of, that might be a case that certain, some people I meet have an issue with weight from the moment they're born. Other people, it might be when they're 30 or 40 or 50 or 60 or 70. And I've had 80-year-olds come in who would tell me, I've been on a diet for 50 years and can you help me?
Gosh.
And it's a case of, again, treating people and treating them earlier. So early diagnosis, early intervention. We have put all our eggs into the prevention basket. We've, it's all about kind of health literacy and knowing about healthy eating. There's a difference between knowing about healthy eating and being able to do that in the face of the environment we live in. So absolutely, kind of policymakers, politicians, public health people, there is a big onus to change the environment you live in, to change advertising, to change the ads that are popping up.
Oh my goodness, the ads are awful for kids. But even like, look at that, like sporting events sponsored by alcohol companies. Like, you know, it's a dangerous kind of dichotomy really there, isn't it? Because it's like, you know, let's put all our eggs, let's, you know, these elite sporting events where everyone is super and ultra healthy, well, one would hope, but then it's sponsored by
and again, there's a whole science to that marketing. I am not smart enough at all to understand what has been promoted to me and marketing and why I think the way I think.
Subliminally. Absolutely. As well. Yeah.
Like again, the whole way the supermarket aisles and how they're set up and kind of where certain foods are placed and why we go for them. You know, so again, that's why, you know, so much of this is not within our control.
Yeah.
But doesn't mean we don't have a responsibility. So again, I constantly am bringing this back to kind of, this is no different than asthma, blood pressure, depression, any other medical issue. You know, if somebody has asthma, you know, doesn't mean they don't have to look at kind of smoking and the environment they live in, dust at home, physical activity, you know, all those things. But that doesn't stop us from offering them an inhaler that will improve the quality of their life, that they will take long term, but that they will be healthier and they will feel better and they'll have a better quality of life as a result. But again, even by virtue of the fact that, you know, let's say I spend 40 minutes with somebody chatting about their history, chatting about treatment. In my previous existence as a GP, I'd bang somebody on a cholesterol tablet in 5 minutes. Yeah. We wouldn't have a 40-minute discussion about it. We should maybe, but we wouldn't, because that's different. That's cholesterol. That's a proper medical problem. It's not your fault. But weight, you know, the onus, and, you know, the onus is to explain, to go through everything, to kind of talk about it. And that's vitally needed because that information isn't out there for people. And like everything in the world, there is increasing amounts of information, but it's not always good information or evidence-based information.
And it's coming from all sources and you're getting lots of different ideas. Like I said, Atkins diet, keto, intermittent fasting. And people jump from one to the other within a relatively short space of time because they're not getting the results that they need. And then they're obviously...
And you'll see, and again, that's the other problem online is people are utterly confused. And again, like I said, it's like religion. There's the low carb keto community, and you know the people talk about the carbohydrate insulin kind of model of obesity, and it's actually carbohydrates and insulin that's causing kind of weight issues. Whereas you'll have the other kind of calorie in, calorie out kind of camp, and all these people have a little war with each other online.
Well, bread is bad, pasta's bad. Yeah. You know, as you said, no, there's no bad food.
I'm sitting back and kind of going like, okay, well, you can kind of argue this, that, and the other, but again, can we not help people, you know, manage this in their life if it's causing an issue for them?
Yeah.
And support them.
See, that's not sexy, Mick. No. It's sexier to say, this will work.
This is the answer. This is the cure. But yeah, and that's the problem, is it is nuanced and it's individual. Like again, each person is dealing with different things. And I get to meet people for a split second in time relative to their life. And I have no concept the things that people are going through. When you hear people's story, it's phenomenal. Yeah. The stuff people are dealing with physically, psychologically in their life. And again, but it's a case that, you know, that is potentially contributing to their issue. But again, like I said, just because this is not our fault doesn't mean we don't have a responsibility to address it. But if we are addressing it, we should be doing it in the right way. So that's where kind of, again, educating people in society why this is an issue and why it's not simple, educating healthcare professionals in how to have these conversations, moving away from blame and shame, moving towards kind of, you know, supporting people, kind of treating people long term, and kind of even identifying people who might be at risk before they have an issue, you know, for earlier kind of intervention or kind of, you know, we know that if I'm prescribing somebody a medication, let's say for pain or a medication for asthma or, you know, a medication for blood pressure, if that medication is associated with weight change, warning the person, kind of saying, look, this can cause some increase in appetite for some people. If you notice that, come back to me. It's about kind of concentrating, let's look for a medication that's more weight neutral for you if that's already a concern. So again, I think it's nuanced, it's complex, and then also kind of talking about there is evidence-based treatments available, and we should use them. We need to be fighting and pushing for these medications to be reimbursed, because that's the biggest.
Can I get on that task force, please? Because I'm, you know, I'll be massively.
We should set up a committee or something about it.
I think so, because I just think the balance of pros and cons, once they're used correctly, the fear there is that, you know, they'll start to be prescribed, you know, for that, like that fat belly, you know, someone wants to go to their wedding and that. But we need to trust that they won't be, that healthcare professionals are going to make the right judgment as well. So, and I think there's a certain level of like infantilization there, isn't there? Like, oh no, we couldn't possibly allow it across the board because then it's going to be prescribed on a willy-nilly basis. Like, you know, I think that it's really, really important that it's there for people to use, because like you said as well, you know, if only a certain amount of people can afford this treatment, that's, you know, how many people are being underserved as a result.
Couldn't agree more. Yeah. Absolutely. And that's why it needs to be made available across society, not based on somebody's kind of income or wealth, based on their health needs.
Yes.
You know, like you know, we are allowed to treat blood pressure and cholesterol, and that's the other kind of confusing thing when you actually look at the bigger picture, is that how many of the kind of complications of weight do we treat?
I know, you know, it's crazy.
Whereas, and I'm not saying that every person is going to have medical issues as a result of weight, but if somebody does, you know, again, we're treating the result, not the cause. So if we go upstream and treat the cause, it's the same as kind of if I focus on my macros and my protein and my calories, that's kind of treating symptoms. Why don't we go upstream and say, oh, why am I taking in these in the first place? Let's treat the biology. Let's treat the appetite system that is dysregulated. Because if we treat that, as a result of that, then naturally people will have different preferences for food, will not take in the same amounts of food. So, but they'll do it passively without trying, because they're being treated.
And I think the point that you made very early on is the biology and our makeup, and the fact that my appetite is different to yours, and you know, that caveman inside you, and that thermostat you were talking about that you reach is just so important.
And how our body defends against weight loss. It's not natural to lose weight. You know, again, we evolved to survive when food is scarce. We are not supposed to be thinking about our long-term health. We're supposed to be doing the most pleasurable thing there is to do today, because that's how the caveman lived. You know, he's not thinking about 20 years down the line. He's thinking, how can I get food?
Or pensions, or his retirement package.
It's somewhat unnatural to be thinking about long-term health. You know, and again, it's even just to get that around. You know, I was always, I'm you know, not a great lad for kind of running or kind of exercising. I don't think I'm not built for it. I'm built for kind of going in straight lines through lads on a rugby pitch more than anything else. But I used to go running, and I was like, you know, other people are doing this and I'm miserable and I hate it, but I know I have to do it for health. But we're sold this idea that kind of, you know, this healthy lifestyle, if you're doing it, the butterflies will be flying and the sun will be shining and it'll be great. Like, it's a slog. It's hard work.
Sucks.
It's miserable. For a lot of people, this runner's high, I never got that, but like I was kind of waiting for it and it didn't hit. And then I was like, something I'm doing wrong. Like maybe I'm not running fast enough or far enough.
Yeah.
But again, it's a case of we're sold this kind of, you know, healthy lifestyle is kind of really enjoyable. It's hard work.
Yeah, you know, or it has to be a certain way, or you have to feel a certain way. But I would always say to people as well that find something that you love doing. Like, there's definitely something out there in a physical capacity that everyone should love, like, you know, whether it be dancing or even going for a brisk walk or something like that. So I think that it's finding that thing. Don't be thinking you have to run that 10k, isn't that right? Because I know loads of people that absolutely hate running. I love it, but they hate it.
You know, like, again, the barrier it can be to some people, like the gym and kind of that environment. So exactly as I said, finding something, you know, to be physically active, and knowing that being physically active, we will be healthier, we will feel better psychologically and physically, and it is an integral part of managing weight and health long term. But we're not going to exercise weight away. And again, you know, in the same way as people do very restrictive eating patterns, some people do very, not unhealthy, but kind of very not dangerous, but they do kind of patterns of exercise, kind of maybe that are not kind of good for them, or they're focusing on certain types of exercise, and they're looking for kind of weight loss, and they're very frustrated when they don't see it. Yeah,
another extreme of the diet culture, and this is only because I've an interest in it. So I actually like UFC. I follow it. And a lot of the fighters there, they would cut their weight to an extreme level, and like, you know, no water even before a fight. And what they used to do is they used to be able to rehydrate with IV fluids just before the fight. But now they're not even allowed to do that, because I don't know, it's a stigma attached to having to use IVs in the first place, I suppose. But as a result of that, then their brain has less fluid around it, and they're more susceptible to injury as well. And I know that's an absolute extreme version of dieting, but it just goes to show you how I suppose culturally acceptable it is that even in a professional sport, people are, you know, praised for being able to cut to a certain weight, get to that weight to be able to fight at a certain level. It's quite messed up, isn't it, really?
Absolutely. And again, that kind of plays into also, these body transformations that you see, and people are kind of, I might have patients coming back and they feel that other people's attitude towards them is different when they're losing or have lost weight. And there's that, what are you doing? And what's your secret?
You look
and
great.
What diet are you on? And the problem is, I've had people kind of say to me, I've been on diets and diets and diets, and they seem to work until somebody tells me I look great. And then the weight starts coming back. So again, is that the destination kind of psychologically in their head? And then their eating patterns kind of change as a result? Or again, is it because it's the same? So again, I think it's all wrapped up in this kind of aesthetic, this kind of the diet culture that we have. Whereas kind of, I think we need to shift the way we think about it. We need to focus on health. We need to shift to living our healthiest life day to day, and acknowledge that some people need treatment, need support, need behavioral interventions, medication or surgery. And that's not a cop-out. It's not a quick fix.
It's not the lazy man's route out. No,
it is evidence-based treatment.
Yeah. And so you have lots of resources on your website. I was looking at it. What is the website? I forget the name.
www.mybestweight.ie. I'm on Twitter and on Instagram as well. Haven't gotten brave enough for TikTok or any of those things. I think I'm a bit long on the tooth for that.
Well, I thought so too, but I was told you really should be on it, even just to be on it. Yeah. But in terms of the pointing at the different things that are traveling around and everything, it's it's a bit mad.
That would give me nightmares, I think.
I know, it is a bit mad.
I think kind of, myself and my colleague, Professor Carol LaRue, who's also in the clinic with me, and we have Dr. Orla O'Reilly. Again, we all think in the same way. We have kind of nutritionists, we have exercise physiologists, again, all kind of treating this along the medical model. Biggest thing for us is not whether somebody goes on treatment or signs up to a treatment plan. Biggest thing for us is sharing that understanding of why this is not our fault. Our weight is not our fault. It's not something we can control. But if it is affecting our health, then we can treat that, and long term our health will improve as a result of that. So I think it's sharing that understanding. That's a successful consultation to me. Not whether somebody starts on a medication, not whether somebody is referred for surgery, not whether somebody kind of engages in the behavioral. A successful consultation for me is that somebody feels listened to, they feel supported, that they appreciate that this is a medical issue, that they gain an understanding. And again, all of that information is on kind of videos on our website. But I think, over and above, I think it's changing the way we talk about weight, the way we think about weight, is arming people to, in an educated way, have these conversations with their healthcare practitioner.
Yes.
It's, arming people, that they can go to their GP and they can say, I'm going to make an appointment to chat about my weight.
With confidence and not feel embarrassed, because that's what people have been saying. They're embarrassed to go in and talk about it.
Yeah, and also supporting GPs and supporting healthcare professionals.
Without a doubt.
Because again, if somebody, we don't know what we don't know. So it's kind of increasing the awareness of this. And certainly I know the Irish College of General Practice are working really hard on trying to increase kind of awareness and education. And there's lots of kind of different organizations. Actually, I would encourage anybody who is kind of interested in this area. There's another fantastic organization called the Irish Coalition of People Living with Obesity, or ICPO. And again, they're on social media and they have a website. It's a patient advocacy group who do fantastic things about education and advocating for people living with obesity to increase resources and increase treatment. They have support meetings for people online and in person who have had maybe bariatric surgery or have had a journey themselves. And they are vocal and they are excellent. They are really well educated and informed, and they speak well because they have the lived experience. And all of these discussions about weight, we should include people who have lived experience, who've lived through this, because they're vital. I think it's the whole adage of nothing about us without us. So they need to be included in these discussions. So the ICPO are a great organisation for people to look up as well.
That's great. You've been so informative. It's been great. And I know loads of people will have benefited from this chat. I ask my guests 2 questions at the end of every session, and that doesn't have to be anything to do with the discussion that we had today. So it is, if you could advise young people today, any bit of advice, what would it be? And the second one is, what is the meaning of life?
Oh, wow, this is much more difficult than the other chat. God, I was much more confident talking about the other stuff. So the first one, what would I say to young people? I think that the one piece, well, I could give lots of advice, but the one thing I would say would be affect the begrudgers. That there are always people in our lives and in the world who are going to be negative, who are going to try and pull us down, who are going to make kind of judgments and assumptions about us. And we need to be not as conscious of those people. We need to make the decisions we want to make for us and not worrying about them. I've always kind of said in my life, I regret the things I don't do, or I don't regret the things I do. I regret things I don't do.
And you learn from your, if you do something and it was the wrong thing to do, you learn from that experience. Isn't that right?
I never have regretted anything I've done. It's the things I haven't done that I regret. So I think that is affect the begrudgers. I think is a big thing.
That's a good one.
And I think particularly in Ireland, we're very good at begrudging. So that's another thing. As far as what is the meaning of life?
Yes.
Oh, Lord. So without a few drinks in me, I could give you a different answer after a few pints. But I don't know what the meaning of life is, but I know for me, the meaning of my life is contentment. And I kind of had an out-of-body experience kind of last weekend where I was sitting on a Sunday morning, sun was shining, I was having coffee, kids were playing on the trampoline outside, I was making breakfast, my wife was reading the newspaper, and I had just the most kind of overwhelming sense of contentment that for first time in I don't know how long I can remember, I wasn't chasing something. I wasn't thinking, I'll be happy when this happens, I'll be happy when I get there, I'll be happy when I achieve that. It was just a case of, I suppose, being able to be present in that moment and mindful of how lucky I am and the things I have in my life. And I just had just contentment, I think, overwhelmingly, and I know it sounds very glib and everything else, but it's just it's something I think we're always chasing something. We're always kind of thinking about the future and when I achieve that. But I think acknowledging the kind of positives in our life, and I'm exceptionally lucky in my life, so I'm very grateful for that.
That's lovely. Mick, thank you so much. It's been an absolute pleasure.
Not at all. Thanks for having me.
Thanks a million.